Many people face barriers to staying healthy and to accessing quality health services. These barriers range from discrimination to inability to pay or difficulty getting to services. Health inequities are differences in health that are unfair, preventable, and fixable. We must ensure that everyone has what they need to lead healthy lives. This means removing obstacles to good health for all people, no matter what their age, education, ethnicity, sex, gender, geographic location, or financial situation. It means not only ensuring fair access to health services, but that people also have healthy food, education, a clean environment, a safe place to live, and decent working conditions. It also means tackling sexism, racism, and classism, including in the way we set up our laws and policies and health and social services. WHO is working with countries and partners to measure inequalities and address inequities in health. Health is a human right, not a privilege. It's time to build a fairer, healthier world for everyone, everywhere.
Around the world, people are living longer, but often with multiple diseases and conditions that require care over many years. And unfortunately, too many people are not informed or consulted in the care they receive. In some countries, only 1 in 3 people have the risks of their treatment explained to them. 1 in 5 people have at least one unnecessary test. And up to 40% of health spending is wasted due to inefficiency. Healthcare should not be like this. Remember, people live with their condition 24/7, not only when they seek care. That's why people-centered care is so important. People-centered care means ensuring that health services are tailored to people's needs and are provided in partnership with them rather than simply given to them. It means care where people, families, and communities are respected, informed, engaged, supported, and treated with dignity and compassion. People-centered care can have lasting benefits. It improves the trust, experience, and outcomes people have from care, the confidence and job satisfaction of health professionals, and the quality and efficiency of health systems. People-centered care can increase access to health services and reduce unnecessary use of services. Ultimately, it means people get the right care at the right time and in the right place. But too often, this type of care is not standard practice. Implementing people-centered care requires fundamental changes in our approach to healthcare. It means rethinking how health services are organized, managed, and delivered. It means shifting away from asking, "What is the matter with you?" to "What matters to you?" Around the world, the World Health Organization is working with countries to design health systems that put people and their needs at the center of care. Because that's the health care that everyone deserves.
Hello there. I'm Lulu. Let me tell you about the Action for Healthier Families, or the AHF Toolkit. First, what is the AHF Toolkit for? The AHF Toolkit was made to help families understand health issues and risk and adopt healthier behavior. By doing so, we hope to prevent people from getting sick or help them recover from diseases, such as non-communicable diseases like cancer, heart attack, stroke, diabetes, and chronic lung disease, as well as other illnesses. So why families? Because they're important. Home is where we first learn healthy or unhealthy behavior and get exposed to a healthy or unhealthy environment. It's important that all family members are aware of health problems and that they learn what they can do as a family to address these. How does the AHF Toolkit work? Before we go step by step, let's look at what's inside. The AHF Toolkit has 4 components and is packed and ready for use in one village. One AHF toolkit has 50 family tree kits, one kit for one family, and one village health map kit intended for the use of the local health leader. One copy of the AHF Toolkit User Guide for community health workers to use as a reference, and one copy of the AHF Toolkit Primer for those who want an overview of the AHF Toolkit. Now that we know what's inside, follow me as I guide you on how to use it. Before visiting a family, we must prepare the following: one family tree kit, pencils, markers, past health records of the family to help family members remember past visits to the health center, and blank forms so we can make notes on other family members as well. We should also bring referral forms in case someone has to be referred to a health facility. Diagnostic devices to get blood pressure readings of the adults and to record other information such as height and weight. We should also prepare medications, supplies, and health information and education materials from WHO and the Health Ministry. We also have to make sure that the cameras in our phones are working so that we can take photos of the family tree and add them to their health record for future reference. Once we have those in order, we can proceed with facilitating the family tree exercise. First thing we have to do is introduce ourselves and the family tree kit. Second, we should set up the family tree board by writing family name and introducing the characters. Third, we identify and discuss health issues relevant to the family, like heart attack, stroke, and chronic obstructive pulmonary disease. The fourth step is to identify and discuss the health risks that the family may be exposed to, like physical inactivity, secondhand smoke, and sugar-sweetened beverages. Now that we have a better understanding of the health risks of the family, the fifth step is to identify and discuss actions that the family can take. Actions they can commit to, like physical activity, not smoking, and drinking water. This also includes going to the doctor for consultation. We can help out by filling out referral forms for the family to bring to the doctor. After going through all these steps, it's time to conclude the visit. We should briefly go over the family tree with the family and instruct them to keep it and review it from time to time so they can keep track of their health. We can check it when we next visit or when they come to the health center. Remember to take a photo of the family tree so we have a copy for their medical records. Now that we know how to use the family tree kit, we can start visiting families in the village to help them improve their health through the family tree exercise. After conducting the family tree exercise in many families, we have a better understanding of health concerns in the village and are now ready to conduct a village health mapping exercise. How does the activity work? First, we identify the common health issues and risks from families we visited in the village. We place these stickers in the inner circle. Second, we identify structures and resources in the community. We place these stickers in the outer circle. After mapping common family health issues and risks, and available community structures and resources, we can now discuss actions towards better health of families in the village. We place the family actions on top, and after discussing and agreeing on options for the village to take, we place community actions below. Ultimately, we can organize these proposed actions in a community health action plan, with person in charge and a time frame. Now we're all set. We can now help improve the health of families in our communities through the use of the Action for Healthier Families Toolkit. When we all work together, our village will be a healthy community that we and our families will enjoy.
Health is shaped by the actions and behaviours of individuals and communities. Individuals, health workers, policymakers, and government leaders make decisions every day which affect people's health. Strategic communication is a field of technical expertise which can help to shape these decisions. Communication can influence whether somebody takes up or quits smoking. Communication can help a parent decide to get their child vaccinated. Communication can be a key determinant of the health and well-being of women in a remote community. Communication that understands the audience, the drivers of their behaviour, and communication which is understandable, accessible, credible, relevant, actionable, and timely can improve awareness, shift attitudes, change policies and behaviour, ultimately contributing to better health. The digital age has profoundly changed the way people engage with each other and the world. The majority of people in most countries now get their news from the internet and social media, rather than traditional news channels. Many have easy access to information and advice from online peer groups and influencers. Information and misinformation is shared and received at unprecedented speed. The pace of information flow, the rise of online influencers, and declining trust in governments and institutions presents both challenges and opportunities for WHO and member states in the Western Pacific region. At the same time, the evidence base for effective communications is expanding. Governments, civil society, and the private sector are increasingly using behavioural insights, data collection, and evaluation to make smarter investments in communications that lead to demonstrable health improvements. This changed landscape demands that we, WHO and our member states, also change how we communicate. Communicating more strategically requires moving away from a focus on outputs, products, and activities, and towards a focus on the outcomes and impact of communication. We need to focus more on communication which targets a particular audience for a specific purpose and responds to real barriers or gaps in understanding or behaviour, to contribute to a specific change. Targeted, evidence-based, measurable, and impact-driven. These are the principles at the heart of what we call Communication for Health, or C4H. By working together to scale up C4H, we can help make the Western Pacific region the healthiest and safest region in the world.
We live in a world where undernutrition and obesity can exist side by side in the same country, home, or even person. Foods high in sugars, salt, and/or unhealthy fats are leading to unhealthy diets and are one reason why children may not be growing healthily, while causing other people to develop overweight or obesity. The consumption of unhealthy diets is heavily influenced by marketing. Easy access is fueling this new nutrition reality, but thankfully, change towards a healthier future is possible. By having a sustainable healthy diet made up of a variety of foods that are safe for consumption, we can promote health and have better abilities to fight illness. How do we do this? Good nutrition for women during pregnancy and for children in their first 1,000 days of life, including breastfeeding, sets them up for healthy adulthood and future generations. We should eat more fresh fruits and vegetables, whole grains, pulses, nuts and seeds, and less sugary drinks and foods high in sugars, salt and unhealthy fats. The less of these foods we buy, the more the food industry will be encouraged to produce foods that contribute to healthy diets. We can also call on our leaders to make the right decisions so that every person, everywhere, can afford and access good nutrition. When people like you and me, industries and governments work together to make positive changes, we can create a healthier world.
Air pollution is the biggest environmental risk to health.
The air is so polluted that it's darkened the sky, leaving homes and their occupants cloaked in smog,
leading to heart, brain, and lung disease, including cancer.
Of the 7 million deaths due to air pollution each year, 1/3, or 2.2 million, occur in the WHO Western Pacific region. Women, children, and older people are particularly vulnerable. When polluted air is inhaled, microscopic particles penetrate deep into the lungs, heart, and blood vessels and increase the risk of death from heart disease, stroke, chronic obstructive pulmonary disease, and lung cancer. Air pollution comes from homes, transportation, industry, coal power plants, solid waste burning, and the use of fire to clear land for agriculture. Burning of solid fuels like wood, coal, or dung at home for cooking, heating, and light causes indoor air pollution. Vehicles emit harmful exhaust, particularly in large cities. Factories, oil refineries, and coal power plants release a lot of dangerous dust and gas into the air. Solid waste burning and agricultural burning emit health-damaging smoke that can spread between communities and across borders. Air pollution is an emerging public health crisis in our region. The World Health Organization supports governments in tackling the root causes of air pollution. Winning actions to reduce air pollution include more investment in renewable energy and low-emission power generation, clean waste and agricultural management, green, safe and healthy cities with energy-efficient buildings, safe and affordable public transport systems using clean fuel or electric power, and pedestrian and cycle-friendly roads, urban planning for more green space, clean fuels for cooking, heating and lighting at home. Air pollution threatens our health, our climate and our very existence.
But this is the issue. Without involving other sectors, we can't really effectively address. We have to come together and to think how we can influence other sector who has solutions on these issues. We call it change agent.
Stronger leadership and bolder actions by governments are crucial in tackling this public health emergency. It's time to accelerate action to combat air pollution.
Populations in the Western Pacific region are aging rapidly. More than 240 million people aged 65 and over live in our region. And this number is predicted to double by 2050. Population aging has implications for societies, including a shifting burden from communicable to non-communicable diseases. But aging also brings opportunities for individuals and societies. With early investment and coordination across sectors, countries can reduce healthcare costs and enable older people to participate in and contribute to societies. WHO's proposed regional action plan on healthy aging guides countries to promote a healthy older population by transforming society and health systems, providing community-based integrated care, encouraging innovation, and strengthening monitoring, surveillance, and research. Let's act now for significant health, social, and economic returns.
Todo Pito, 7 healthy habits na go na go. Move more, eat right. Ang tamang pagkain at pagkilos ang pundasyon sa malusog na pamumuhay. Ngunit sa Pilipinas, marami pa rin ang hindi nakakakain ng tama at hindi sapat ang ehersisyo. 2 sa 10 bata na wala pang 5 taong gulang ay kulang sa timbang, habang 1 sa 10 bata naman ang sobra sa timbang at obese. Sa tamang diet at ehersisyo, maiiwasan natin ang lumalalang banta ng malnutrisyon at obesity. Maiiwasan din natin ang mga non-communicable diseases tulad ng diabetes, sakit sa puso at stroke. Para tayo'y manatiling malusog sa anumang edad, sundin ang mga tips na to. Gumalaw ng 30 to 60 minutes kada araw. Tangkilikin ang active transport tulad ng pagbibisikleta at paglalakad. O gumawa ng mga aktibong gawain tulad ng paglilinis ng bahay. Kumain ng healthy at iwasan ang mga pagkaing mataas sa asukal, asin at taba. Ugaliin ang pagbasa at pagsuri ng mga food labels. Iwasan ang mga inuming mataas sa asukal tulad ng soft drinks at uminom ng di bababa sa 8 baso ng tubig kada araw. Pag naghahanap ka ng panghimagas, kumain ng prutas sa halip ng mga minatamis tulad ng cake at ice cream. Tara na't labanan ang malnutrisyon at mga sakit. Ugaliin nating mag-move more, eat right, for a healthy Pilipinas. Todo 7. 7 healthy habits na go! Be clean, live sustainably. Ang kalusugan natin nakaugnay sa kalinisan ng ating kapaligiran. Kasama rito ang malinis na hangin, ligtas at malinis na tubig para sa lahat. Wastong pagtatapon ng basura at iba pa. Ang hindi wastong pangangalaga ng kapaligiran ay nagpapalala o nagiging dahilan din ng climate change. Lagpas 5 milyong Pilipino ang naaapektuhan nito. Umaabot sa 20 bagyo ang dumadaan sa Pilipinas kada taon. Apektado ang tirahan at kabuhayan ng mga tao. Dulot din ito ang pag-apaw ng mga ilog na nagiging sanhi ng matinding pagbaha. Ang dala nitong maruming tubig baha at iba pang pinsala ay nagiging sanhi ng mga sakit, impeksyon at kamatayan. Kaya sama-sama nating pangalagaan ang ating kapaligiran para iwas sakit at mapanatiling malusog ang katawan. Sundan natin ang mga tips na to. Maglakad o magbisikleta para maiwasan ang paggamit ng mga sasakyang nagbubuga ng usok na nagpaparumi sa hangin at kapaligiran. Bawasan din ang pagkonsumo at pagbili ng mga bagong bagay, lalo kung hindi naman kinakailangan. Reduce, reuse, recycle. Hindi natin maiiwasan ang mga kalamidad, pero kaya itong paghandaan bago pa ito dumating. Magtanim ng mga puno para mabawasan ang pagbaha at gumawa ng survival go bags. Let's be clean, live sustainably. Todo ang kalusugan kapag malinis ang kapaligiran. Todo 7. 7 healthy habits na go! Care for yourself, care for others. Alam mo ba na 1 in 5 Filipinos ay may mental health problems? Ito ay ang ikatlong pangkaraniwang health condition sa bansa, lalo na sa kabataan. Ang depression ay isa sa maraming uri ng mental health disorder. At ang Pilipinas ang may pinakamaraming kaso ng depression sa Southeast Asia. Ang mental health kasing importante rin ng physical health. Para maingatan ang mental health mo at ng iyong mga minamahal sa buhay, gawin ang mga sumusunod. Mag-exercise o tumutok sa mga hobbies. Nakakabawas ito ng stress at pwede ka pang humubog ng mga bagong skills. Mag-breathing exercises, tulong pangpakalma. Breathe in for 4 seconds. Hold breath for 7 seconds. And exhale for 8 seconds. Gawin ito 4 times, twice a day. Makipag-connect sa iyong pamilya at mga kaibigan. Ipadama ang iyong pagmamahal sa regular na pakikipag-usap, pag-text o pag-video call sa kanila. Care for yourself, care for others. Pangalagaan ang isa't isa para sa malusog na kaisipan. Todo 7 healthy habits na go! Don't smoke. Lessen alcohol. Say no to drugs. Ang pag-abuso sa alak, yosi at droga ay di lang delikado sa kalusugan ng gumagamit. Nakakaapekto rin ito sa kalusugan at kaligtasan ng iba. Ang problemang ito ay laganap sa Pilipinas at sa buong mundo. Kaya alagaan natin ang kapakanan ng bawat Pilipino para sugpuin ang adiksyon sa alak, yosi at droga. Gawin ang mga sumusunod. Tigilan at huwag simulan ang paninigarilyo. Lahat ng uri nito ay nakakasama sa kalusugan. Ang paninigarilyo ay sanhi ng mga sakit sa puso at baga. Kahit hindi ka alcoholic, drink moderately. Huwag lumagpas sa 4 na baso ng inuming nakakalasing anuman ang okasyon. Ang sobrang pag-inom ng alak ay masama para sa iyong kalusugan. Kilalanin ang adiksyon bilang isang problema sa kalusugan na maaaring matugunan sa medikal na pamamaraan. Pumunta sa mga drug rehabilitation facilities ng DOH o pamahalaang lokal kung ikaw o ang iyong kakilala ay nangangailangan ng tulong. Tara na! Suportahan ang ating kapwa na magtagumpay laban sa adiksyon. Don't smoke. Lessen alcohol. Say no to drugs. Tawagan ang Substance Abuse Helpline o Quitline sa mga numbers na ito. Todo pito. 7 healthy habits na go na go. Practice safe sex. Ang sexual and reproductive rights ng bawat Pilipino ay dapat inaalam, nirerespeto at ipinaglalaban. Ngunit dahil sa iba't ibang balakid, maraming suliranin ang kailangan pang matugunan. Noong 2017, 70% ng lahat ng mga babaeng edad 15 hanggang 17 ay maagang nabuntis. Panahon na para itaguyod ang sexual and reproductive health. Simulan na natin sa mga hakbang na ito. Pag-usapan ng sex sa iyong pamilya. Huwag mahiya. Sa tamang kaalaman, maiiwasan ang di planadong pagbubuntis at mga sexually transmitted infections. Di pa kayo ready magka-baby? Alamin ang iba't ibang contraceptive at family planning methods. Magtanong sa doktor o health worker tungkol sa pros and cons ng mga ito. Tigilan na ang stigma sa sex. Magtanong, makinig, makipag-usap at maging supportive. Let's practice safe sex for a healthy Pilipinas.
Many people face barriers to staying healthy and to accessing quality health services. These barriers range from discrimination to inability to pay or difficulty getting to services. Health inequities are differences in health that are unfair, preventable, and fixable. We must ensure that everyone has what they need to lead healthy lives. This means removing obstacles to good health for all people, no matter what's their age, education.
Good morning, everyone. Welcome to the first DOH-WHO Cancer Control Stakeholders Summit. May we introduce to you our host for today's event. Dr. Feli Marilyn Lorenzo is a retired professor of the Department of Health Policy and Administration at the College of Public Health at the University of the Philippines, Manila. Dr. Lim championed the teaching and conduct of research on health policy studies and policy analysis for 28 years. She is currently the Vice President of the Nurses Christian Fellowship Philippines. Together with Dr. Lorenzo is Miss Maria Dolores Manalastas. Dolly is a nurse by profession who had been exposed to different clinical setup at different tertiary hospitals. She is now working with the Department of Health as a health program officer of the Cancer Control Division. Let us welcome our host, Dr. Lynn and Miss Dolly.
Good morning.
Good morning, everyone.
Good morning, everyone. Okay. Morning, everyone. Good morning to all our guests and participants from all over the Philippines and also from those abroad. Binabati namin kayo sa ating mga attendees na kasama natin ngayon. Umagang ito dito sa Zoom, pati na rin ang mga nanonood sa ating mga live stream sa Facebook at YouTube. I am Dr. Feli Marilyn Lorenzo. For today, I will be Doc Lynn.
And good morning, everyone. I am Dolly Manalastas from the Department of Health Cancer Control Division, and we are your hosts for the first DOH-WHO Cancer Control Stakeholder Summit with special focus on childhood cancer.
This summit is brought to you by the Department of Health in collaboration with the World Health Organization. Binabati rin namin ang mga representatives ng iba't ibang organisasyon at grupo na nakikilahok sa Day 1 ng ating virtual summit. Ito ang kauna-unahang summit sa cancer, kaya ito ay exciting. Magandang umaga po sa inyong lahat. Let us begin today's event with an invocation to be followed by a short prayer and by the Philippine National Anthem.
ng mabuti. ka namin. Hallelujah.
Let us continue with a short prayer. Our dear Lord and Heavenly Father, we come to you with praise and thanksgiving for gathering all of us together. Be in our midst as we discuss how best to pursue cancer control in our country for the betterment of Filipinos. We also thank you, Lord, for all our guests, our audience, and those that are part of this stakeholder summit. And we pray, Lord, that you would be in our midst as we discuss and look for the solutions that you would lead us into. May, Lord, bless the meditations of our hearts and the words of our mouth, and may they be pleasing to you, O Lord. All of these we ask in Jesus' most precious name. Amen. To continue, let us all tune in for the Philippine National Anthem.
Mga kababayan, ang pambansang awit ng Pilipinas. Kayang magiging kasasinananan, alam ng puso sa likid mo'y buhay. Lupang hinirang, tuyagan ang mahiting, sa mandulupin, ikapasisigil, sa ganatang tutok sa simoy at sa langit mo banggaw, ay hinatang tulagaw, isang pagkayang minamahal, ang isang ng matawad mo'y tagumpay na nag-iibig, pagpituin at araw niya kailan ang hindi mag-ibig, luman ang araw ng walang pagsinta, buhay langit sa piling mo, aming bigaya ng pagkay mga amin, ang mamatay ng dahil sa'yo.
Muling pagbati sa ating mga guests at participants para sa Day 1 ng First DOH-WHO Cancer Control Stakeholder Summit.
As we begin today's program, we would like to acknowledge again the presence of our speakers and participants, healthcare workers, advocates, and most especially to the cancer patients joining us this morning. We really hope that this summit sparks hope as we all continue to work together for cancer control. Let us also acknowledge those who are watching our live stream today through Facebook and YouTube. Magandang umaga po sa inyong lahat.
Before we proceed to the program proper, we would like to present the summit reminders to ensure that this virtual gathering will be enjoyable and productive for all of us. Sessions will be recorded, and to accommodate a lot of people, we will be live on Facebook and YouTube. If you have any questions or comments that are contributory to our summit today, use the chat function on Zoom, Facebook, and YouTube. There will be people who will man those. Encourage others with your comments, and we are trying to make this as interactive as possible with features like Mentimeter. Okay, I think that's all our summit reminders.
Yes, yes, Doc. So now that the summit reminders have been presented, I think we now ready to begin the program. So Doc Lynn, bakit nga ba tayo nagtipon ngayong umaga?
Ang event na ito ay ang kauna-unahang Cancer Control Stakeholder Summit na hatid ng DOH at WHO. Ang layunin ng first day ng virtual summit na ito ay mapag-usapan ang status ng National Integrated Cancer Control Act o NICA at ang mga hakbang na ating tinatahak para sa mas malawakang pagpapatupad o implementasyon ng batas na ito. And with that, to officially welcome us on day one of the first ever DOH-WHO Cancer Control Stakeholder Summit, here is a message from none other than the Secretary of Health. Everyone, please virtually welcome Dr. Francisco T. Duque III.
All our distinguished speakers and panelists this morning, my fellow officials in the Department of Health, our partners from the World Health Organization, ex-officio members of the National Integrated Cancer Control Council from the DSWD, DOLE, DILG, PhilHealth, and FDA, honorable non-ex-officio members, namely Dr. Samuel D. Ang of the Surgical Oncology Society of the Philippines, Dr. Corazon A. Niel Angel from the Philippine Cancer Society, Dr. May Dolendo of the Southern Philippines Medical Center, Dr. Rachel Marie B. Rosario of the Philippine Society of Hospice and Palliative Medicine, and Ms. Carmen Oste of the Cancer Coalition of the Philippines. Our patients, people with cancer, support groups, and to all Filipinos and people sharing time with us. Indeed, a pleasant and most productive morning to us all. I'm honored to welcome you to the very first DOH-WHO Cancer Control Stakeholders Summit with special focus on childhood cancer. This year's theme is adopted from the 2021 celebration of the International Childhood Cancer Day. Better survival is achievable through our hands. In order to intensify cancer awareness and the observance of cancer-related advocacies, the Department of Health collaborated with the World Health Organization to launch this summit in alignment with the mandate of Republic Act 11215, the National Integrated Cancer Control Act, or NICA. This summit is a key strategy in bringing together stakeholders to commemorate the second anniversary of NICA's enactment, in conjunction with the celebration of International Childhood Cancer Awareness Month, which seeks to advance global advocacies for childhood cancer around the world. In line with this, Day 1 of the summit focuses on NICA's implementation. Day 2, on the other hand, is given over to childhood cancer, in support of the goal of the WHO Global Initiative for Childhood Cancer to improve the quality of life of children by achieving at least 60% survival and reduce the suffering of all children with cancer by 2030. Cancer remains a national health priority of our government, with efforts continuing to mitigate its significant socioeconomic detriment in individuals, families, communities, the health system, and the society at large. Through the enactment of NICA, we have already begun the necessary groundwork to improve our cancer service delivery for everyone. The resource stratified framework has already designated the specific hospitals to become comprehensive cancer centers, and the strategic plan for NICA, which will map out, prioritize, and sustain all our whole of system and life course approaches across the cancer control continuum, is well underway. May this two-day virtual summit allow everyone, especially the most marginalized groups and those living in far-flung areas, to participate. By giving their voices a platform, we can effectively work together to operationalize and strengthen NICA towards the salvation of more lives. I heartily thank everyone who is sharing their time with us in this summit. And together, we can pave the way for better outcomes and better lives for everyone. Let us make the most of the time on our hands and continue our work to counter this scourge of cancer.
Thank you so much, Secretary Duque, for that wonderful welcome message. We all agree that it is very vital to work together for the implementation of the National Integrated Cancer Control Act, which directly translates to saving more lives. And to proceed, for us to start our summit, let us know who are the speakers for today's event.
It is exciting to have a lot of excellent speakers to talk about and celebrate Cancer Control Summit.
That is correct, Doc Lynn. And to start, we have Honorable Christopher Lawrence Tigo, the Chair of the Committee on Health, Senate of the Philippines, to deliver his keynote speech.
Distinguished guests, a pleasant day to all of you. It is an honor to join you today in the first Cancer Control Stakeholders Virtual Summit. We would like to congratulate the Department of Health in collaboration with the World Health Organization and other specialty organizations in conducting this summit. Ang cancer ay isa po sa mga pinakamabigat na sakit na dinadala hindi lamang ng pasyente kundi ng buong pamilya at ng komunidad. Maliban po sa pisikal na karamdaman, naghahatid rin po ito ng matinding emosyonal at mental na paghihirap. As we commemorate the International Childhood Cancer Awareness Month, we also pay tribute to the families, medical health workers, and numerous civil society groups who offer their service and strength to the brave children who are fighting against cancer. May we gather inspiration from their courage and commitment in taking steps to find new cures, conduct thorough researches, strengthen cancer prevention programs, and make healthcare services accessible to all Filipinos. In line with this year's theme, better survival is achievable through our hands. Let us all work hand in hand to achieve the global goal of reducing the suffering of all children with cancer and improve their quality of life. As chair of the Senate Committee on Health, I am always one with you in the fight against this disease. In fact, during the budget deliberation last year, I pushed for the additional budget for the National Cancer Control Program for 2021. With the support of my colleagues in the Senate, we were able to add 500 million for this program. Rest assured that I will continue to fully support all programs and continue to work hard to help ease the burden that the cancer patients and their families carry. The fight against cancer is a collective undertaking. Patuloy po tayong magbayanihan at magtulungan. Maraming salamat at mabuhay po kayong lahat.
Thank you for that wonderful keynote speech, Senator Go. Tunay po na mabigat ang sakit ng cancer. And it is just right to improve cancer services as what you have supported in doing. Let us all work together hand in hand towards this goal. And also, to deliver a speech this morning, we may call on Honorable Angelina D.L. Tan, Chair of the Committee on Health, House of Representatives. Let's give her a virtual welcome.
Secretary Francisco Duque III, Senator Christopher Lawrence Go, Undersecretary Maria Rosario Bergere, Attorney Dante Gueran, Director General Rolando Enrique Domingo, Assistant Secretary Nestor Santiago Jr., Director Beverly Lorraine Ho, Dr. Rabindra Abiyan Senghe, Dr. Andre Elbawi, Dr. Gil Vicente, Dr. Feli Marilyn Lorenzo, Mr. Peter Paul Perez, the men and women of National Integrated Cancer Control Council, ladies and gentlemen, magandang umaga po sa inyong lahat and a meaningful celebration of this year's International Childhood Cancer Awareness Month. It is my pleasure and honor to be invited to speak on the occasion of the first Cancer Control Stakeholders Summit with special focus on childhood cancer. I am delighted to note that at the center of this important activity is our mutual yearning to reign over the cancer disease, which is the leading cause globally or leading cause of death globally and is expected to increase up to 60% annually by 2040. This is unacceptable, not only because cancer to a large extent is preventable and curable, but because each of us can do something to stop it. That is crystal clear for those of us who enacted and supported the landmark Republic Act No. 11215, otherwise known as the National Integrated Cancer Control Act or NICA, which was passed into law on Valentine's Day of 2019 to pave the way for the adoption of an integrated and comprehensive approach to health development that includes the strengthening of integrative, multidisciplinary, patient and family-centered cancer control policies, programs, systems, interventions, and services at all levels of existing healthcare delivery system. We know that preventing cancer and improving cancer survivorship requires the scaling up of essential programs and increasing investments for robust prevention of cancer, better screening, prompt and accurate diagnosis, timely and optimal treatment, responsive palliative care and pain management, effective survivorship care, and late effects management and rehabilitation. Making cancer treatment and care more equitable and affordable for all, especially for the underprivileged, poor, and marginalized Filipinos, including children, must be our continuing collective concern. Against this backdrop, allow me to provide you with the keynotes that I hope will guide everyone as you embark in the various activities scheduled for today. As one of your keynote speakers, I believe that my role is similar to that of an orchestra conductor, that is, to enable the orchestra to start playing harmoniously Handel's iconic Messiah, although they know the piece well enough that they no longer see the need for a conductor after getting started. Starting is usually the hard part, and like a conductor that interprets the music and ensures that the volume of the instrument is balanced so that nothing is drowned out in the process. Allow me at this point to key in some important notes that you may find helpful as you go along in this summit. Number one, inasmuch of the aims is to present the WHO report on cancer, Dr. Elbawi is here with us to do that, and the status of NICA's operationalization, juxtaposing RA 11215 with RA 11223 or the UHC Act, will allow our battle against cancer to have a stronger anchorage that will enable complementary mechanism to work, particularly in the provision of preventive health services as stipulated under Section 4B. Lessen the incidence of preventable cancer in adults and children. And C, prevent cancer recurrence, metastasis, and secondary cancer among survivors and people living with cancer of the NICA, as well as Section 2A, an integrated and comprehensive approach to ensure that all Filipinos are health literate, provided with healthy living conditions, and protected from hazards and risks that could affect their health. B, a healthcare model that provides all Filipinos access to comprehensive set of quality and cost-effective, promotive, preventive health services. And Section 30 of the UHC law that provides for a comprehensive and coordinated approach to health development with emphasis on scaling up health promotion and preventive care, increasing health literacy with focus on reducing non-communicable diseases, implementation of population-wide health promotion programs and activities across social determinants of health, and finally, designating the schools as healthy settings to formulate programs and modules on health literacy and rights to be integrated into the existing school curricula to intensify the fight against the increase in prevalence of non-communicable diseases through, among others, the effective promotion of healthy lifestyle, physical activity, proper nutrition, and prevention of smoking and alcohol consumption among students. Number 2, piecemeal policy approach will not do it. It has to be comprehensive, coordinated, and even imaginative, which means to say that RA 11215 or NICA will not win the war against cancer all by itself. It has to engage, aside from UHC Act, RA 1148 or the First 1,000 Days Act, otherwise known as Kalusugan at Nutrisyon na Magdanay Act, along with House Bill number 8558 or the Mandatory Immunization Program Act that is now pending in the Senate and seeks to enhance the country's efforts towards disease prevention by expanding the mandatory immunization program for all ages and, very importantly, vigorous advocacy of legislative measures that will amend the first comprehensive law on tobacco control in the country, will largely remains to be ineffective to this day. That is House Bill 2140. The loophole in the provision on the prohibition of smoking in certain public places, which doesn't make specific mention of public places such as parks and playgrounds, entertainment halls, concert grounds, convention centers, and sporting arenas, where the general public, including children, pregnant women, and elderly engaged in different activities, needs to be addressed. The composition of Interagency Committee on Tobacco, or IAC Tobacco, which is headed by the Department of Trade and Industry instead of the Department of Health, is likewise a concern considering that RA 91 or 9211 is fundamentally a health law. We need to urgently pass a measure, difficult as it is, that will remove a representative from the tobacco industry among members of the IAC Tobacco, which is vested with exclusive power and function to administer and implement the provision of the Tobacco Regulation Act of 2003, since that which is being regulated and monitored cannot and should never be part of the monitoring and regulating body. The country badly needs an evidence-informed health legislation that will regulate the manufacture, importation, sale, distribution, use, advertisement, promotion, and sponsorship of electronic nicotine delivery system and electronic non-nicotine delivery systems or ENDS or ENNDS and heated tobacco products or HTPs in order to ensure that no one, especially children, women, and elderly, will be exposed to emission of these harmful products. ENDS or ENDDS and HTPs must be strictly regulated as they are designed to mimic conventional cigarette smoking that makes initiation of non-smokers, especially the youth, to nicotine dependency a cause of concern. Restricting age sales, prohibiting minor use, and policing marketing rules to ensure that promotion do not target minors, as well as undermine smoking cessation messages, are significant policies that must be put in place or into place if we are to effectively fight cancer. Number 3, and this is the last note, on September 26, 1998, Vice President Al Gore, during the rally dubbed as the March Coming Together to Conquer Cancer in Washington, D.C., said this: "The power to fight cancer comes from the heart and from the soul." Such powerful conviction echoes largely William Faulkner's stubborn refusal to accept the defeat of human condition in the face of tragedy, anguish, and travail, believing that, and I quote, man will not merely endure, he will prevail. He is immortal not because he alone among creatures has an exhaustible voice, but because he has a soul, a spirit capable of compassion and sacrifice and endurance, unquote. Put simply, the power to fight cancer, more than policies, programs, systems, and interventions, which need to be institutionalized and operationalized, comes from the heart and from the soul. It comes from the spirit that is capable of compassion, sacrifice, and endurance. May we never forget that we need only to look into the eyes of every cancer patient and survivor to realize that it is hope that made them survive each painful and dreadful day living a life with cancer. That same hope must guide and steer us today as we begin to put flesh into the spirit of the law that seeks to champion cancer control along with the inclusion of the childhood cancer as an actionable challenge in the global and national health agenda, even as we face the worsening COVID-19 pandemic in our lifetime. Mabuhay at maraming salamat po.
Thank you very much, Honorable Tan, for your insightful speech highlighting the salient features of the National Integrated Cancer Control Act and how each one of us can contribute in promoting a better healthcare system, especially for cancer control. It is also true that the hope from our beloved patients should be our motivation and driving guide in our endeavor to realize the cancer law. Now that we have heard our keynote speakers, we now proceed on why we are all here this morning. Our lineup of speakers for today are experts in the field of cancer control and will be sharing updates on cancer here in our country and globally. So for our first speaker, she has committed decades of public service and also contributes to nurturing our soon-to-be public health leaders. She is currently the OIC Undersecretary of the Department of Health's Public Health Services team and the official spokesperson of the department. Let us all welcome Dr. Maria Rosario Esvergere, joining us today to discuss the progress updates on the National Integrated Cancer Control Act, or NICA, implementation.
Good morning to all of you. I am truly honored to be part of the first DOH-WHO Cancer Control Stakeholder Summit with a special focus on childhood cancer and with the theme, Better Survival is Achievable Through Our Hands. Let me give you the progress updates on the implementation of the key provisions of the National Integrated Cancer Control Act. First off, for the information of everybody, I was the chair of the technical working group that developed the implementing rules and regulations of RA 11215, or the National Integrated Cancer Control Act, which was signed by the Secretary on August 9, 2019, barely 6 months after its enactment on February 14, 2019. Similar to the implementation of the Universal Healthcare Act, the NICA implementation is progressive, responsive, and resilient. During this COVID-19 pandemic, carrying out the identified priorities of the NICA based on the Strategic Plan 2021 to 2030 is a gargantuan task not only for DOH, but also for the stakeholders concerned. Hence, we had to start with the quick and big wins until June of 2022 and progressively carry out the long-term strategies until 2030. The National Integrated Cancer Control Council has already conducted 4 meetings and various urgent and important matters were already discussed on May 12, July 29, August 13, and September 3 of 2021. True to its mandate, the Council approved the National Integrated Cancer Control Strategic Plan 2021 to 2030, which provides the blueprint and the overall direction in the planning, financing, implementation, monitoring, and evaluation of the NICA. By virtue of the Notice of Organization, Staffing, and Compensation Action, or NOSCA, issued by the Department of Budget and Management, the Cancer Control Division was established under the Disease Prevention and Control Bureau. It currently has 5 permanent and 1 job order staff. We are still awaiting for the hiring of the division chief and an administrative assistant, hopefully within the year. The Cancer Control Council already approved the framework of the National Integrated Cancer Control Program and the Strategic Plan 2021 to 2030. The vision of the program, which is Cancer-Free Philippines, Philippines Free from the Burden of Cancer, supports the vision of universal health care, wherein Filipinos are among the healthiest people in Asia by 2040. The program also supports the WHO's various global initiatives or strategies for cancer, such as childhood cancer, cervical cancer, breast cancer, and the Cancer Registry, which will contribute to the attainment of the United Nations SDG indicator numbers 3 and 4, that is, to reduce premature mortality from non-communicable diseases by 30% by 2030. Ultimately, we all wanted to achieve the Filipino aspiration dubbed as Ambisyon Natin, that is, the Filipinos will live long, healthy, and productive lives by 2040. This is the why, or our shared purpose in cancer control. The 5 strategies or pillars of NICA, namely good governance and sustained financing, equitable access to quality services across the cancer control continuum, strategic partnerships and collaborations, robust information systems and technologies and cutting-edge research, and capacity development and institutional strengthening are all aligned with the Universal Healthcare Law and the World Health Organization's global strategies or initiatives. This is the how, or the portfolio of our investments and undertakings to realize our vision. Our mission, which is people, patient, and family-centered healthcare system, delivering accessible, equitable, and inclusive quality cancer control services. And our goal, which is by 2030, provide cancer control services to the general public and to at least 50% of all Filipino cancer patients, improving their quality of life and reduced overall mortality from cancer by 10%. Finally, the WHO, or all the stakeholders with a sense of purpose and with steadfast commitment in cancer control. We should all be working closely together in achieving our aforementioned vision, mission, and goal. At this time, we already created the following technical working groups to assist the Council in the decision-making, policy development, and program management. The TWG for blood cancer control, the TWG for prostate cancer control, the TWG for the control of gastrointestinal cancers and other digestive diseases, the TWG for the control of liver cancer and its risk factors, TWG on retinoblastoma control, TWG for the National Palliative and Hospice Care Program, TWG for breast cancer control, and TWG for the control of lung cancer and its risk factors. The Philippine Cancer Center Management Office had already developed its own strategic plan to carry out its mandate under the NICA, namely to be the center of excellence in cancer care, research and development, and capacity development, to oversee the network of cancer treatment facilities in collaboration with concerned Department of Health units, to be the primary repository of all cancer registries in the country, and to generate data and analysis to be used for research as well as for policy and decision making, to serve as a point of contact for international institutions for networking, to continuously improve the center and to contribute to global development in cancer control. The 100-bed hospital for rare cancers is expected to be constructed by 2025. The full operationalization of the Philippine Cancer Center and the establishment of the Philippine Network of Cancer Centers are part of our long-term strategies. The appointment of the permanent executive director of the Philippine Cancer Center is a quick win. All cancer patients, persons living with cancer, and cancer survivors are now considered as persons with disability, and as such, they are entitled to a 20% discount and non-discrimination privileges. The revised Department of Health Administrative Order, which included cancer and rare diseases in the Philippine Registry for Persons with Disability, is already for signing of the Secretary. Currently, the Department of Health has an ongoing project with the WHO entitled Technical Assistance for the Assessment of Cancer Registries and the development of guidelines for strengthening of population-based and hospital-based cancer registries. The output of this project will be a big help in the establishment of our first ever National Cancer Registry, including the expansion of population-based cancer registry and the standardization of hospital cancer registries. Since 2020, the observance of various cancer awareness months are already included in the annual DOH calendar. Every February is the National Cancer Awareness Month. The TWGs created will take the lead in organizing the activities for the calendar for Cancer Awareness Months in sync with the Health Promotion Bureau's Healthy Filipinas and Consultayo campaigns. The Cancer Control Program, in collaboration with the Department of Health Academy of Health Human Resources and Development Bureau and the University of the Philippines Open University, developed and piloted the online training course on leadership and capacity building for cancer control. This training aims to orient and capacitate the primary healthcare workers, the regional coordinators, the local chief executives, and all other stakeholders on the principles and practices of cancer control. The National Palliative and Hospice Care Program under the Cancer Control Division, in collaboration with the Jose B. Lingad Memorial Regional Hospital, developed the Manual of Operations, Procedures, and Standards, and the basic training course on palliative and hospice care for primary care providers. A series of dissemination fora for all stakeholders will be conducted for the MOP this fourth quarter until early next year, while the basic training course will be rolled out next year by the regional offices of DOH. Lastly, launched this month is the more inclusive Cancer and Supportive Palliative Medicines Access Program, formerly called Cancer Medicines Access Program for Breast and Childhood Cancers. It aims to provide free medicines to our patients with breast, childhood, lung, prostate, blood, head and neck, gynecologic, and gastrointestinal cancers, and for supportive and palliative care. This Cancer and Supportive Palliative Medicines Access Program is fully funded by the Cancer Assistance Fund. This year, we were able to get 756 million budget for this program. And for next year, the Department of Budget and Management already approved the 786 million budget for this. The higher the budget for this program, the more patients that we can help to alleviate their financial burden. The Department of Health Administrative Order on the guidelines for the implementation of Cancer Assistance Fund, which covers this program, is already in the pipeline for signing of our Secretary. This is the list of our 27 access sites where our patients can enroll in the Cancer and Supportive Palliative Medicines Access Program and avail of our free medicines. Please be reminded that the Philippine Children's Medical Center, the National Children's Hospital, and the Asian Hospital and Medical Center will provide only childhood cancer medicines together with supportive and palliative medicines. For any questions or clarifications, you may coordinate with the Cancer Control Program of the Department of Health. With these updates on the National Integrated Cancer Control Act, cancer patients can now expect better access to a more responsive and affordable healthcare services. Thank you very much and good morning to all of you.
Thank you very much, Yusek Berhere, for that very encouraging presentation on the NICA. It surely will make a lot of difference for our patients to access important health services and support. Now, for our second speaker, we are fortunate to have the technical lead for the Cancer Control Program of the World Health Organization, mobilizing communities to produce guidelines and tools to enable stakeholders and to support governments for the betterment of people living with cancer. He joins us today to discuss the WHO World Cancer Report 2020. Friends, let us all welcome Dr. Andre Ilbawi.
Good morning, good afternoon, dear colleagues. Honorable Minister of Health, Honorable Chair, Mr. Go, Honorable Chair, Ms. Tan, esteemed Dr. Maria Rosario, dear WR of the Philippines and Country Office, friends, colleagues, advocates, may I begin by saying thank you. Thank you for your leadership in the global cancer agenda. You have set a model, an inspiration for countries in the region and globally. You have taught us how to advance the cancer agenda by putting people at the center of our work. Cancer is a deeply personal disease. Yet you have created a situation in the Philippines where the cancer agenda is moving forward because of people, because of political will, and because of the tireless efforts that each of you has made. For the next 20 minutes, we would like to reflect on what is the status of the global cancer agenda. What have we worked to do within the WHO to advance key principles, and where can we as a community respond to support cancer patients not only in the Philippines, but globally? In order to do so, I'd just again like to thank the organizers, their leadership, for really elevating cancer to its rightful place as a public health priority. There will be three take-home messages today. The first is that the cancer burden is increasing. We must set priorities and act now. Second, by investing wisely, cancer cases and deaths can be avoided. Third, universal health coverage is our guiding principle. Cancer care for all is achievable, but it requires capacity building and reducing inequalities. We all know very well. The cancer burden is a global phenomenon. We see that cancer cases are more common often in high-income countries, but we expect this to continue to shift to a burden that every country in the world feels. In fact, cancer will be the leading cause of premature deaths in effectively every country within the next 10 years. What does this mean in practice? 20 million cases per year. But another way to understand it is to make it a bit more personal. 1 in 2 or 1 in 3 people living in Europe or in the Americas will develop cancer in their lifetime. 1 in 2 or 1 in 3. This is clearly a disease that affects all of us and our families. And one may wonder, what is the situation in a country like the Philippines? In fact, the numbers are not that different. It is 1 in 5 or 1 in 6. So again, cancer is a deeply personal disease because we know that it will impact us. If in fact, most of us have already been directly impacted. And what will happen in the future? Here's where the numbers get more concerning. In the next 20 years, we expect that the global cancer burden will double in countries like the Philippines. Now, again, this is a term that we use quite openly, terms like double or triple. But to make it a bit more real, that means double the number of hospital beds, double the number of providers, double the number of machines, investments, infrastructure. You in the Philippines are already thinking about this, as we just heard. You are already making the necessary investments. But the reality is still that in countries like the Philippines, we will see this profound increase in the cancer burden. So what is it that we can do? Why is this cancer burden going to double? This brings us to our first question. Why is the cancer burden increasing and what can we do about it? Here are 5 possible options. First, that we are increasing our exposures to risk factors, such as tobacco, air pollution, unhealthy diets, alcohol use. Second is simply a byproduct of more people being born each year and therefore more people being diagnosed with cancer. Third, people are living longer. We know cancer increases with age. It does happen in children, a very important diagnosis, but it does increase in age and that can contribute to the increase in cancer burden. 4, that there are new risk factors that we're discovering and new risk factors that are driving the cancer burden. Or 5, other. Perhaps I can pause and allow each of you to reflect on this question and answer it. Well, here is the preliminary answer. The main reason we see the cancer burden increasing is in fact because we are living longer. This is a success in public health. We see life expectancy increasing in nearly every country around the world. And as people live longer, their likelihood of being diagnosed with cancer will increase. Let's look at the situation in the Philippines. Using the population-based cancer registry in Manila, we see in the past 20 years, in fact, the cancer burden has almost doubled. If we dissect it out further and ask, well, what is the age standardized incidence rate? That is, what is the likelihood that an individual will develop cancer in their lifetime? In fact, it's been quite stable, and in the recent past has decreased. If we look at birth rates, yes, it is still quite high, but not particularly high in the Philippines. The primary reason why the cancer burden is increasing in a country like the Philippines is in fact because people are living longer, life expectancy of 71 years. But that doesn't escape the reality that this will cause a rising burden on our health systems and on our families, that cancer will become increasingly frequent and it will impact all of us. What does this mean for our ability to achieve the SDGs? Well, in a country, and here's the data from the Philippines, you have made good progress. If we look at what is the progress towards the achievement of premature mortality, specifically in cancer, there's been a decrease, not exactly where the target would be of 4.2%. So what investments do we need to make? What priorities do we need to set to achieve the SDGs? We often speak about best buys. Best buys are an important set of prioritized interventions that we focus at the WHO on. These are often policies or programmatic interventions focused on NCD or non-communicable disease prevention. This will help. But in the next 10 years for the cancer agenda, the impact will not be enough to reach the SDG target. When we do look at the interventions, there is merits to focus still on prevention, even in the near term. By improving tobacco control, which currently contributes to about 20% of cancer deaths in the Philippines, we can in fact reverse some of those impacts within 5 years. So it will help us achieve the SDGs, but again, it will not be enough. The second dimension is to invest in management services, to invest in cancer control as you are doing. The unfortunate reality is that for many countries in the world, these investments are simply not possible. Cancer is not seen as a development priority, and the domestic investments have been insufficient to date to reverse the effects of the increasing cancer burden and have caused a stagnation in premature mortality reduction related to cancer. So for us to achieve the SDGs, for us to truly achieve universal health coverage, we need to think more on how to invest in cancer services. So what types of investments are needed? How do we do so equitably and have high value for money? Well, here's the first question. How much money do we need? If we ask what is the per capita expenditure, general government expenditure in health, and then of that, what is the specific expenditure in cancer that is required for us to achieve a basic set of essential cancer services. In a country like the Philippines, general government expenditure is on the order of $50 per capita. So what is it that would be required for us to have a basic set of essential services in cancer? Thank you for pulling up the survey. The reason this is an important question is because there's a perception that cancer has to be expensive, that cancer will drain government budgets, that cancer is not value for money. But the reason this question is important is because, in fact, it does offer us value for money. It does not have to be expensive. As we see the answers coming in, we can add as a point of reference childhood cancer. A basic set of services for childhood cancer, that is, to ensure every child with cancer in a country like the Philippines receives the care that they need. This could be done for less than $1 per capita, less than $1, and could save thousands of lives. And for us to take on, in fact, the entire cancer portfolio and focus on common cancers, priority interventions, we could do all of that for, as we are rightly seeing, $5 per capita. $5 per capita. In a country like the Philippines, that's about 5 to 10% of the general government expenditure, and that is feasible. But the key here is to understand where should that money go? Because there is an interest in focusing investments on high technologies, on expensive targeted therapies, when in reality, there are more directed interventions that we can focus on that allow us to achieve value for money. I'll just pull the slides back up. Please let me know if there's been a delay in seeing them. But as we talk about these investments, we have to meet the current reality. The current reality is that government budgets are strained by competing health needs. Cancer is not the only health priority, and that is the reality in which we work. So when we look at what types of investments are being made, we start with the question of, are governments investing in cancer care? Do we see specific budget line items related to NCDs or to cancer services? Unfortunately, less than 10% of countries have invested in cancer and have budgeted their cancer control plan to reflect the investments that are needed, less than 10%. When we look at, well, if there is an investment, what types of services are being prioritized? We often see investments in screening programs that are often less value for money than a basic set of services. We see investments in expensive technologies that are driving up cancer budgets. We see governments investing in expensive machines, but not in the people that are delivering the services. And what is the consequence? And this is a statistic that keeps me awake and keeps many of us awake at night. Cancer patients are suffering financial hardship. So when all comes to a point, cancer patients are asked, you need to pay out of pocket. This is a phenomenon globally, not a phenomenon to speak specifically in a country like the Philippines. The Philippines, in fact, has been leading the tide in reversing the effect of the catastrophic expenditure on cancer. But for many countries around the world, a person with cancer is told, you have a disease that we could treat, but we don't have the money to do it. So you must pay out of pocket. People sell their possessions. They sell assets. They sell their homes. They forego educational opportunities so that they can access cancer care. And this isn't happening for just 5, 6, 10% of people. In some countries, this is happening for 70, 80, 90% of all cancer patients. This is really unacceptable. This is something that, again, we appreciate the leadership that the Philippines has shown to say, we can do better. We can protect our cancer patients, because when someone is diagnosed with cancer, it has a huge effect on their families. And they're showing this is not just an effect in a 1 year or 5 year time horizon. Families are being pushed into bankruptcy, into poverty. Children are losing educational opportunities. This is a generational impact. So what can we do? Let's focus now on the solution. We're talking about, in a country like the Philippines, on what really is value for money. And when we look again at what are the investments that are needed, it's not just in the infrastructure, in the hospitals, but it's also in the workforce. The workforce is the most ignored investments in cancer care. that should be prioritized as we look to scale up capacity. And the justification is there. Investing in cancer does offer a positive return. It has social value, it has productivity gains, and it is absolutely informed by a value for money perspective. So what types of investments are needed if we are going to bridge the gap in survival, if we are going to save lives? If we look at a country like the Philippines and ask, what is the survival from breast or cervical cancer? According to your registries, it's somewhere along 40, 50, 60%. In some middle-income countries, in fact, it's lower, 20 or 30%. So what
Recording in progress.
The options are 0 to 5%, 6 to 10%, or 11 to 20%. There is a perception that cancer screening is a primary solution to detect cancer early. And if we develop screening programs in breast cancer, lung cancer, colon cancer, ovarian cancer, that can help us detect cancer early. But the response, the actual answer here is 0 to 5%. In the United Kingdom, as an example, a country that has invested millions and millions of dollars into their screening programs, only 5% of cancers are detected through those screening programs. That doesn't mean all cancer screening programs are the same. Some are more effective than others. And for us, we prioritize cervical cancer screening. But let's look at this decision-making matrix at a country level, a country in which we work. This country had very advanced breast cancer, more than 50% presenting with stage 3 or stage 4 disease. We met with them, we said you have two options: focus on screening or early diagnosis. Screening could be $1 to $2 million of programmatic cost per year. They would have to increase the number of mammography machines from 3 to 50, increase the workforce, and have an impact of about 200 to 500 lives saved per year. But focusing, in fact, on early diagnosis would achieve the same and would be able to do so with a less overall budget impact. So the focus in this country is cervical cancer screening because it can save lives and prevent the disease, and then early diagnosis programs for other cancers. And these, when we talk about value for money, are some of the guiding principles. Focus on programs that work, programs that are known to have an impact. And the last message is now, how do we deliver this to an entire population? How do we achieve universal health coverage in cancer and in other areas? We often think about medicines being the bottleneck, but when we break down the cost drivers that will inform expansion and service coverage, the primary driver is in fact workforce. So the question that we ask is, how can we build a workforce that is fit for purpose, ready, and able to scale up to meet the country needs? The starting point is very challenging. We know that many countries, including the Philippines, have workforce densities that are unable to meet the country needs. And this is a major limitation to expand coverage. What we also see is that the policy response is weak. Deficits in cancer control plans or health workforce policies related to cancer competencies or occupations. And this is true for all necessary workforce, including cancer surgery, cancer nursing, and other important domains. The policy solutions are quite plentiful, but we have challenges in implementing these policy solutions because we often focus just on increasing the number of graduates. But there are other dimensions to think: improving attrition rates, dealing with optimization strategies, improving patient-centered or person-centered care. And using these guiding principles, we in fact can achieve the scale that allows every person with cancer to have an integrated, person-centered approach to their care needs. A last brief set of slides on what WHO is doing, just to share with you some of the work and our focus. Of course, we focus a lot of our work on cancer prevention, on risk factors that are related to all NCDs, the primary one being tobacco, contributing to 25% of all cancer cases globally. Alcohol, obesity, very important risk factors that are increasing. A second general category to focus on is infectious causes. And here is where we've seen major progress with vaccinations. First, it was hepatitis vaccination, and now it's vaccination against human papillomavirus or HPV, another area where the Philippines has been driving the agenda forward. But we also have to be ready because the cancer burden is expanding, and part of the driving risk factors include dimensions such as air pollution, a very important discussion that we were very pleased to hear from today and from yesterday's pre-summit. Finally, we have the initiatives, and thank you really for the leadership that the Philippines has shown in childhood cancer, cervical cancer, and breast cancer. We're very pleased also to know that our key partners, like Dr. Catherine Lam from St. Jude Children's Hospital, is here to also reflect how childhood cancer can be elevated as a priority, how we can take childhood cancer and make it a tracer for advancements in the cancer agenda. We know you have the leaders, many of whom we know personally, like Ms. Carmen. We thank you for that leadership for driving the agenda forward. But it has really been your entire community that has been participatory in these initiatives and has helped us shape it. So the last slide. Is the cancer burden rising? Yes, and doing so rapidly. Why? Primarily because of life expectancy, but tobacco still is a primary problem. How do we reduce deaths from cancer? To focus on UHC. UHC is the driving principle because we know it can work, and we in fact know that it reduces mortality from cancer. Focusing on improving access, improving quality, and ultimately to realize that cancer is part of a development agenda and is part of a human rights agenda. No person with cancer should suffer unnecessarily to sell their homes, to sell their possessions. We thank you really. In the Philippines, you have helped to drive this agenda forward in every imaginable way. And all stakeholders have been able to do this, from your political leaders who have really put cancer in the agenda in a way that really is unparalleled, from your civil society actors and providers that we know many of whom are tirelessly working through COVID to drive forward the cancer agenda and to care for people with the disease. Thank you to the WHO country office and the regional office. You are really an inspiration for us within the organization, and we look forward to working together in the months, years, and decades ahead. Thank you.
Thank you very much, Dr. Andre Ilbawi, for a very comprehensive presentation. There are now requests for copies of your presentation to illuminate many of the points that you made. We learned a lot. The urgency of really providing investments and best buys for cancer is something that you have brought into our consciousness, and the need to invest in actually very meaningful interventions like early screening and early diagnosis has also been brought forth. Maraming salamat po. And so now, let us proceed to the next part of our program. We have invited some guests to share their reactions and comments on the presentation shared by our speakers this morning as commentaries. First, to provide us with his reactions and comments is Dr. Gil M. Vicente, the President of the Philippine Society of Oncology. The floor is yours, Dr. Vicente.
Hello, good morning.
Morning. Dr. Vicente.
Yeah, okay. Yep.
Okay.
Am I clear now?
Yes, we hear you now. Thank you.
Okay. Thank you. Colleagues in the medical profession, distinguished guests and speakers in this Cancer Summit, Professor Andre Ilbawi, Senator Christopher Lawrence Go, Dr. Francisco Duque, Honorable Angelina Tang, Dr. Maria Rosario Vergere, and my colleague, Mr. Paul Perez, my co-workers in the war against the Big C, to the health providers and caregivers of our grieved patients and officer members of this special event, and most of all for those who believe that cancer can be crushed and defeated. Thank you very much for this opportunity, and I think I would like to delve on more important things that have been discussed. Thank you, Dr. Duque, for your call for making the best out of this endeavor. Thank you, Senator Go, for working hard in the Senate and pushing for an additional budget of 500 million. And I think we need more. We need more, Senator Go. So I think we have to have we should push for more budget. And thank you, Dr. Tan, for showing to us, revealing to us the need for a relevant conductor, and that will always be there to modify our actions according to our needs. And thank you for sponsoring House Bill 2140 and 3049 for continuing our fight against smoking. Thank you for all of this, and for believing also what Al Gore has said, fight with our heart and fight from our soul. We should continue also to think with our mind and look for some things which will make us a better place to live in. A cancer-free Philippines, a cancer-free world. And we look forward also to better years. And all of this, we need to look into several things from now on till the several years to come. And thank you, Dr. Vergere, for giving us a update of the NICA. We've been doing this for the past several months. I've been an active participant of this framework, and I think definitely having a universal healthcare system in accordance to or with this NICA project, we feel that true enough, good governance, sustained financing, again, there's the financing aspect, strategic partnership and collaboration, capacity development, and of course, this leading to a decreased cancer risk, decreased mortality. Definitely, we need about 10%, but we need more in order to be successful in our work against cancer control, right? For cancer control. We need cancer registry, definitely, and we need training. And all of this training is very important to make us realize that the world of cancer is really becoming bigger and bigger and bigger. And of course, Dr. Andre Ilbani made us realize some missing links. We need to realize, we need to identify these missing links. And of course, he has told us about the need for looking for the risk factors, and that longer life probably has been contributory to this. But I think we really need to look for the missing link. And because of this missing link, we need to really push through, work more, and invest wisely in this kind of endeavor. Cancer control is definitely one thing that we need to accomplish, and from here on, look forward to a better world. Thank you, Dr. Ilbawi, for showing to us that also that there is an inequality perhaps in cancer care, and we need to establish this, and we need to form a legacy wherein we need to make an equalization, the very poor and the very rich, to have some kind of an equalization for all these things. Thank you very much, and most of all, ladies and gentlemen, we need to work hard. We need to use our mind. We should use our heart and our soul, the very soul. And with this, I say thank you. Mabuhay ang Pilipinas, mabuhay ang WHO, mabuhay tayong lahat.
Maraming salamat, Dr. Vicente. Maraming salamat, Dr. Vicente, for those comments. You made really good points about continuing a really strong fight against cancer. We have to look for the missing links and the gaps that we need to actually achieve to be successful and to invest wisely in cancer control. Those points are very well taken. At this point, before we introduce the next speaker, we'd like to bring you back to the Mentimeter results. The questions that was asked by Dr. Ilbawi during his presentation. So let us look at the results. The first question was, why is the cancer burden increasing? These are very interesting results. The most numerous response looks like that it's lifestyle, which was also mentioned by Dr. Ilbawi, but there's a lot of other factors like longevity, it's not prioritized, lacks preventive measures, unhealthy lifestyle, decreasing lifespan, no budget, the risk factors including smoking and diet was also identified, and sugar also. And then there were health services aspects like no access to services, the out-of-pocket expenses, including decreasing value of money, and the cancer rate increases because of the increasing number of years of people's life. Okay, so this is very interesting. It mostly aligns with the points that Dr. Ilbawi was specifying. Let us look at the number 2 question results. What per capita expenditure is required to provide a basic package of essential cancer services in medium-income countries like the Philippines? And most of the answers were $5 or 250 pesos per capita. And I guess this was the amount that Dr. Ilbawi was saying. It's not expensive to actually provide an essential, a basic package of essential cancer services. And so when it comes down to utilizing the investments and the funds provided for cancer care, it is not much, and we can cover a lot of people if we use it wisely. Meron pang mga humahabol. Now it's an even Steven, $50 per capita or 2,500 and $5. Mamaya, towards the end, we can look at this. Please keep on texting your answers in Mentimeter. Use code 957-10448 after you have downloaded the Mentimeter app. Okay. Is there another question? Or I think that's it. Okay, the percentage of cancers. Okay, so over to you, Dali. Who's our? We're now going to have our next speaker, Dali.
Yes, Doc Queen. But I think we have a question coming from one of our participants from CHD, Dr. Aurora Campita. Secretariat.
I'm sorry, I don't have a question.
Okay.
This hand gesture is always there. Doesn't leave my screen. Thank you.
Thank you for that one, Doc Campita. So now let's proceed to our next reactor to share his thoughts about the presentations this morning. Is the president of the Cancer Coalition Philippines. Let us warmly welcome Mr. Pitel Por Perez.
Hello, good morning, everyone. So to Secretary Duque, to Senator Bongo, Congresswoman Helen Tan, to you, Secretary, of course, Dr. Ilbawi, and my colleague, Dr. Vicente, and to our host, Dr. Lorenzo and Dali. Magandang umaga po. Thank you so much, DOH, and of course, WHO for this opportunity to share a commentary. First things first, I am big congratulations for mounting this first DOH-WHO Cancer Stakeholders Summit with special focus on childhood cancer. I joined the cancer community via diagnosis of my son, who was diagnosed with acute lymphocytic leukemia when he was 3 years old. That was 16 years ago. At that time, the annual average of new cases of childhood cancer in the country was around 3,000 kids every year. I thought that was a lot. I was really surprised by that number, as I remember thinking my son's case was unique and just few in the country. It was an eye-opener, and one doctor captured my feelings then when he said, one child with cancer is one child too many. But fast forward to 2021, that number increased to 4,650, or around 3% of the total new cancer cases in our country. And it's indeed unfortunate that we see the numbers are increasing. And of course, this was captured in the presentation of Dr. Ilbawi. It's easy to feel disappointed. It's also easy to feel more afraid for our children. But of course, we all know that the survival rates are also increasing or improving. I think 16 years ago, it's less than 20%. Thus, we had to work closely with my son's doctor to ensure we get the best possible outcome for him. But now we're tracking far better than that. And we have a very clear objective to even try to hit over 60%. And as they say, hope springs eternal. So the decision to focus on childhood cancer in the maiden edition of this Cancer Summit is indeed a giant step to advance the fight versus childhood cancer. As we know, childhood cancer is not the top cause of mortality and morbidity in our country. We know that's breast cancer and that's lung cancer. Yet we found ourselves focusing on this. And this is quite significant in the era of pandemic because it's sending a very, very strong message that children, being vulnerable as they are not forgotten or left alone. I will not even attempt to capture what a child with cancer or his family goes through, despite my front row experience for over 16 years, as every case is unique and has its own challenges. But hearing Dr. Ilbawi of WHO discuss clear targets and pathways is quite, comforting. I think the awareness, the investments, and all this stuff actually gives us a lot of things to really ponder on and work hard to make things happen. It gives us a lot of hope, which is a powerful position to be in. As we all know, hope is what gives courage in the storms of life. I have to say, though, the WHO numbers are quite alarming. Countries like ours will double its cancer cases by 2014. And 2040 rather, and 2040 is within our lifetime. It's not like a way out, a year ahead. It's within our lifetime, and that is really, quite alarming. That's the reason why it resonated so strongly with us, the call to invest in cancer, and this should be taken seriously by all stakeholders. We need to embrace the idea of value for money. I know countries like us might be difficult, might not be easy, but I think there's no other way but to start really embracing that whole process of determining and defining the value for money. I do believe there are ways around it. It was mentioned towards the end of Dr. Ilbawi's presentation about the global initiative for childhood cancer to achieve at least 60% survival for all children with cancer and reduce suffering globally. And these are points that are showing us clear direction of what we can actually do, but more than that, on how to do it. In our race to save more children from cancer, there are a number of frameworks now that's available for us. And I think the whole presentation of Dr. Ilbawi actually allowed us to dig deeper and dive closer into what we can actually do. And I was trying to simplify it for my own comprehension, coming from the point of view of a patient advocate. It's like getting into a track and field lane, and we see clearly the finish line, which is, of course, the 2030 or 2040. But instead of just finishing alone, we need to reach that finish line with more survivors like we've never seen before. And that's such a big responsibility. And I'm sure it's a responsibility everyone in this call or everyone in this summit is willing to carry. The WHO also decision to make the Philippines as a focus country also came at a perfect time, as of course we now know we have the National Integrated Cancer Control Act, or NICA, which we got a comprehensive update from EU Secretary, and which allows us again to have a solid platform to make things happen. Being actively involved in the crafting of the law and being a member of the IRR of NICA, under Yusek Verheri, I know the true spirit of the law provides every cancer fighter in the country not just a fighting chance, but a winning chance. The 5 key pillars of NICA, from the good governance down to and financing to equitable access of quality services, to the strategic partnerships, to the robust information systems, and the capacity development, is really in good hands because, as we all know, the council's in place and a lot of them are really great champions of our fight. And of course, the announcement of Yusek Verheri about PWD benefits and the non-discrimination clause is such a welcome news. A lot of our cancer survivors have been waiting since the signing of the IRR for this one. So maraming salamat tungkol sa balita na po yan. Thus, the combined news of WHO as well as NICA are two big news, two big push for us. It's like saying we now have what it takes to win this fight and no more excuses. And if we still fail, sorry to say this, I think we should now blame no one but ourselves, because this is our time to truly respond to the challenges of the times. We already have within our reach all the possibilities to change the narrative of cancer, childhood cancer in particular, in our country, and to provide not just a cure, but to set up these children for success and to have the quality of life they truly deserve. And I'm confident the stakeholders here today will not fail. The passion, the determination, the dedication, which I'm so privileged to witness, is just overpowering. Let this passion fly high and use this passion to look into other possibilities aside from what was shared today. We look into field health Z package benefit. This is benefiting enough vis-a-vis the number of new cases that we have. Let's look at LGUs to ensure they have programs for children with cancer, like child lives programs in the hospitals they manage. Let's make our elected officials more attuned to the needs of the cancer community. There are just too many things that we can actually do. And I know we can do it because we have two enabling framework behind us, the WHO Global Initiative and NICA. I was stuck with the good congressman from Quezon, our dear friend and the champion of cancer in Congress, Congresswoman Helen Tan, when she quoted Al Gore and she said, "The power to fight cancer comes from the heart and the soul." I think it captures the passion I was referring to, the passion of every single cancer fighter, either as a patient, as a parent, as a doctor, as a nurse, lab technician, or caregiver is. Such a powerful line that provides a great backdrop to the theme, better survival is achievable through our hands. There's the road to the 60% is long, but I think it's being paved now with what WHO has been sharing with us as well as NICA. And that is what is important. Allow me to end this by sharing a letter I got a few years ago from one brave kid in Philippine Children's Medical Center. He passed this on to me after one Christmas party. And I translated it to English. And it basically said, "Dear Tito Paul, I have cancer, but I have to be brave to fight it. Being brave doesn't mean I'm not afraid. I'm still very much afraid. But I just have to face it and fight it hard to kick it. I cannot do it alone. Please join me in my fight." I think today we are not just joining him in his fight. Through our hands, we are joining him and over 4,000 others diagnosed annually, not just in their fight, but to survive and thrive. Maraming salamat po, and have a good day, everyone.
Maraming salamat po, Mr. Peter Paul Perez, for your very impassioned plea to continue the fight, and remind us that we now have a fighting chance, or a winning chance, as you call it, because we now have NICA. We just have to implement it. And resounding the call of Congresswoman Tan, we fight cancer from our hearts and souls, is really something that we should remember in all of this. Maraming salamat po. In that note, we'd like to thank also all our speakers this morning, from Secretary Duque to Senator Go, to Congresswoman Tan, to Dr. Andre Ilbawi, to also our commentators. We'd like to thank you from the bottom of our hearts for contributing to this very important discussion today that will give us the ammunition to fight cancer and control cancer in the Philippines more strongly. We are ahead of our time. And thank you to the speakers for keeping to your time. So now we can actually entertain questions, and there have been a lot of raised hands so far. But may I please start by asking Dr. Ilbawi from the Secretariat. What do you think, Dr. Ilbawi, will it do to have the stakeholders for cancer support cancer control very effectively and cost efficiently in countries like the Philippines? Dr. Ilbawi?
Thank you for this important question. A country like the Philippines benefits from the passion of the advocates and civil society, such as what we heard from Mr. Perez. What we see in many countries is that without strong political leadership, the civil society will often go in their own direction. What the Philippines is able to do, and what has been very important to succeed in the implementation of a cancer agenda, is to have stakeholders come together under the government leadership. And this is what is very unique in a country like the Philippines. So you have now national strategies, you have very important legislation to support the rights and needs of people with cancer. And the question becomes, how do we organize ourselves as a community to deliver on that agenda? You very clearly set forth the priorities. Now, how do we assign roles and responsibilities and have accountability mechanisms to ensure that every stakeholder is at the table, is able to make a contribution, and that those contributions are organized? So an important principle that we see in effectively implementing cancer programs is to do it through a coordinated multi-sectoral approach. And this is where we think a country like the Philippines can succeed. People at the table, multi-sectoral actors, an agreement on roles and responsibilities, and a shared implementation approach. Something like this can make all the difference to ensure that everyone's effort, whether it's as small as sitting with a child in a hospital and holding the hand of the family or that child, or as significant as making a major investment from a business to change business practices. Everyone has a role. It's about consolidating it through improved coordination and coherency.
Thank you very much for those important points. We encourage those that are attending our summit today to have your questions ready and raise your hand. We are being prompted by our team. I think I will take the first two, Dr. Dali, and then maybe you can go ahead with the rest. Can we call on Angie Fernandez, who is raising her hand, and then we will follow with Enrico Ragaza. Over to you, Angie. Angie? Is Angie unmuted already? Okay. Okay, Angie, can we hear from you now? Okay, let's move to Enrico and go back to Angie. Enrico Ragaza, please.
Yes, good morning. I hope you can hear me.
Yes, we can, loud and clear.
Yes. I just like to have one comment regarding our cancer management. No, from the talk of Dr. Ilbawi, he emphasized the need for us to maximize our resources. And may I suggest that we look into our different specialty hospitals, which have a lot of investment in terms of human resources, in terms of equipment, and in terms of quality services. All right. I hope they will not limit their patients to those that are their primary mandate. For example, Lung Center, its primary mandate is lungs. For example, the National Kidney Transplant Institute, whose mandate is urology and transplantation. Case in point, National Kidney Transplant Institute, at the moment, its cancer resources are mainly based on the NICA law, I think, or on this integrated law. The resources are mainly for urological cancers. But the human resources in the National Kidney Transplant Institute is not only with urologists. We have good hepatobiliary surgeons, cancer surgeons for pancreas and liver. We have very good colorectal surgeons managing cancer patients of colorectal origin. We have a PET CT scan with its own cyclotron center, with its own cyclotron production center. We have a cancer institute in the NKTI. We have a lot of medical oncologists in NKTI looking into not only urologic cancers, but cancers of all origins. So I am appealing because for the past, since the pandemic started, for the past 2 years, our cancer patients in NKTI are suffering. They don't have anywhere to go. Their doctors are there, but their admissions are limited because of the problems with the pandemic and because of the reduction in the number of non-uro and non-transplant and non-kidney patients in the National Kidney and Transplant Institute. It's a waste of resources, actually. We have a very good PET CT center there, very good nuclear medicine centers. We have a working multidisciplinary team in cancer, which has been working ever since and producing a lot of discussions with regards to cancers. But we cannot operate on our patients there, which is actually a very, very sad thing. I hope this can be remedied in the near future, not only for our patients, but also for the doctors there who are invested in cancer care. That's all. Thank you very much. And I would like to congratulate all the speakers. They did a very, very wonderful job this morning. And I look forward to a Better Cancer Summit Day, Better Cancer Summit Days in the coming days. Thank you. Thank you.
Thank you very much for those comments and suggestion and impassioned plea. I wonder if Dr. Vicente would like to respond to that. I know you're not the Department of Health representative here, but as the president of the Philippine Oncology Society. Okay, let's move on then.
Hello.
Dr. Vicente, go ahead.
Thank you for acknowledging me. And I think Dr. Ragasa indeed pointed out a very important aspect in this in our strategy for cancer. Indeed, the Philippine Society of Oncology is very much in the forefront, okay? And especially now that our aim really is to involve all the specialties. We are in a multidisciplinary team approach strategy, and all of this in all our endeavors, in all our work, in all the things that we do, we need to establish a cohesive team that will always be there to help our patients. Indeed, this kind of a strategy will forever be our mission and our vision and our advocacy throughout the rest of our life. Having said that, I think we need to establish really all these specialties. We need to make them strong. Dr. Ilbawi work in the workers in the Senate and in the Congress, and also in the Department of Health. We need to be with them in helping them establish a strong a strong pathway towards this goal. Thank you very much.
Okay, thank you so much for that. But I think the plea was also for the Department of Health to consider opening the ability of hospitals to be able to respond to multiple cases and not just for their specialty. Okay, so we will park that. Over to you, Dolly, for the next part of our program.
Yes, thank you, Doc Lynn. Again, we would like to thank again our speakers and also our commentators for their valuable comments with the presentations. And with that aside, I think it is also very important for us to have a break. So let's have a quick 5-minute mental break. Let's drink or have a restroom break and be back again after 5 minutes. Thank you.
Wash your hands as you...
We hope everyone has been refreshed with a 5-minute mental break. And before we proceed to the next part, we would like to read first the messages we have from our guests and panelists here in the chat box. So first, coming from Ms. Carmen Austin, one of the members of the National Integrated Cancer Control Council. The message goes, "Thank you, Andre, for sharing with us the future challenges, current best buys, and meaningful cancer investments to improve or increase survivorship. Your leadership in shepherding the Global Initiative for Childhood Cancer, GICC, and supporting the Philippines team in fighting cancer and supporting families of those living with cancer is most appreciated." So thank you for that, Dr. Ilbawi. And then we have one more here from our reactor, Mr. Paul Perez. "Thank you, Dr. Andre, for the presentation. This will surely go a long way in guiding us more as we navigate through all the challenges of cancer in our country. Mabuhay." And we have one last here from Dr. Gil Vicente of Philippine Society of Oncology. "Thank you very much, Dr. Ilbawi, for your kind words. Likewise, congratulate you for a straightforward presentation and showing us the way to go. Cheers and mabuhay." So Dr. Ilbawi responded, "Thank you, dear Carmen. You have been such an inspiring advocate and leader. GICC advanced because of countries like Philippines that led the way, because of 300 plus experts and advocates that joined the working groups to define the GICC agenda. Thank you for all that you did to support all the technical work. We very much look forward to continue to collaborate with you, with the Cancer Coalition Philippines, the Philippine Society of Oncology, and all the inspiring advocates, providers, multi-sectoral actors, and politicians in the country. Thank you again." So I think that's all from our speakers and commentators. Thank you for those inspiring words. And before we proceed to the next part of the summit, let's watch and follow this health break video.
Wash your hands as you sing along with Pepper.
Wash, wash, wash your hands. Wash them nice and clean. Bubbly, scrubbly, scrubbly, bubbly. Wash them nice and clean.
You need to
wash our hands.
That's right.
Wash, wash, wash your hands. Wash them nice and clean. Bubbly, scrubbly, scrubbly, bubbly. Wash them nice and clean.
Remember to wash your hands for at least 40 seconds. Wash your hands.
Okay, we hope everyone is back and ready for the next part of the program. But before we go there, kamustahin po muna natin ang ating mga audience. Meron po kaming inihandang mga tanong para inyo pong sagutin. So, inaanyayahan po namin ang lahat ng attendees na pumunta po muli sa menti.com at gamitin ng code na 9571048. So, for the first question, we would like to know how is everyone today, and kindly answer, how are you feeling today? So we are now getting answers here. So some answered happy, hungry, so baka hindi pa nagbe-breakfast, excited, inspired. Some said in love. And as you can see, the biggest word that we're seeing right now is inspired. So it's good to know po that this summit let you felt that way. So yeah, others says hopeful, grateful, great. So some are busy. So baka in duty pa po. And yeah, so others said tired as well. So okay. So we have our answers. So the two topmost answers that we have is inspired and happy. So it's good to hear everyone is doing well po despite the cloudy weather. So we have another question that we would like to answer. So for the next one, what do you do to make yourself happy when you are stressed? So kindly go to menti.com and use the code 957104448. So let's see. What are the coping mechanisms? So we have an answer again here. Gardening. So planting. Watching Netflix. So marami pong makaka-relate dyan. Eating chocolate cake. Going to the beach. So we have a lot of answers. Eating ice cream. Traveling. Motorcycle touring. Spending time with the family. It's very important. And we have another one. Unwinding. Family bonding. And as you can see, the topmost answers, the biggest words that we have is eating, watching Netflix, spending time with the family. So I think these are all very important as we are now facing a difficult time during the pandemic. We should not forget what truly makes us happy. So for the last question, sagutin po natin itong tanong na anong pagkain o inumin ang alam mo na hindi healthy, ngunit hindi mo maiwasan na kainin o inumin. So, isend lang po ulit ang inyong sagot para malaman po natin kung ano yung pinaka-best seller na guilty pleasure ng ating mga attendees today. So, we are getting answers na po, no? Coke, chocolates, lechon, we have lechon, Starbucks, soft drinks, pizza, burger, soda. Okay. Milk tea. So for sure, everyone relates to that. Lucky Me Pancit Canton. Instant coffee. So we also have chicheria or some junk foods. Some answered kare-kare. Okay. So we have another one here, sangyup. Sangyupsal. And as you can see, we have the biggest words po, no? Coke, chocolates, soft drinks, ice cream. So we really cannot deny that we have this comfort food that's sometimes not the healthiest choice. And with this, we need to remind ourselves to look for a healthier option. So as highlighted po yesterday by our health promotion expert, Dr. Meng Madamba, we encourage everyone to move more and eat right, which is one of the key healthy habits that we are promoting. So thank you everyone for participating. Sana po nagising kayo sa ating activity na ito. And now, I think we will open the floor for the panel discussion. So thank you again, Secretariat, for flashing the answers to our Mentimeter. Okay, so we will now proceed to the panel discussion with the topic, a bold ambition to strengthen the National Integrated Cancer Control Program, rising up to the future we want. So in this part of the program, we have invited experts and advocates of cancer control to talk about strengthening the National Integrated Cancer Control Program as we reach for the future that we envision, specifically for persons living with cancer. So to facilitate today's panel's discussion, my co-host, Dr. Lynn Lorenzo, will serve as the panel chair. And for our attendees, feel free to use the chat box to send in your comments or ask questions during the panel discussion. And for our audience watching via live stream on Facebook and YouTube, you can send your reactions and questions through the comments section. So, okay, before we start, let's introduce our panel of experts today. As you can see on the screen, we have here Dr. Beverly Lorraine Siho, who serves as the Director for Health Promotion Bureau and the Disease Prevention and Control Bureau of the Department of Health. Good morning, Director Ho. Also present is Dr. Rabindra Abeyasinghe, World Health Organization representative in the Philippines. Also joining us today are members of the National Integrated Cancer Control Council representing Attorney Dante Aguiran. President of the Philippine Health Insurance Corporation is Dr. Riza Mahela El Herrera, Acting Vice President of PhilHealth's Quality Assurance Group. Also to represent Dr. Rolando Enrique D. Domingo, the Director General of the Food and Drug Administration, we have Deputy Director General Dr. Oscar Gutierrez Jr. Also, we have Dr. Corazon Engalangel, a member of the National Integrated Cancer Control Council and also serves as the President of the Philippine Cancer Society. And lastly, Dr. Rachel Marie B. Rosario, member of the National Integrated Cancer Control Council and the Executive Director of the Philippine Cancer Society. Also joining us this morning, our Director Angeline Del Mundo, Director of the Malasakit Program Office, and Ms. Alison Umanda. We also have representatives from the Senate of the Philippines, Committee on Health, Ms. Beatriz Cruda, Committee Secretary. And we have also Mr. John Carlos of the Office of Senator Bongo. So I think we have our speakers, panelists acknowledged. Dr. Lorenzo, I now give you the floor as the panel chair.
Good morning. Good morning again, everyone. So after that very exhilarating set of speeches this morning, we now will give the floor to experts and advocates to actually express their take on the points raised this morning and probably start and hopefully start a discussion with our audience. For our audience, we would like you to know that we post 3 questions to each of our panel discussants. They may choose to concentrate on just one of these or answer all of that, and they have about 8 minutes, 6 to 8 minutes to give their piece. And here are the questions. First, from the lens of the office or institution that you represent, and considering the status of the implementation of RA 11215 or the National Integrated Cancer Control Act or NICA, and the unmet needs of people with cancer, which specific area do you think the country should focus on? Okay, so that's the first one. The second question, SDG target 3.4 is to reduce by 1/3 premature mortality from non-communicable diseases. That includes attributed deaths from cancer through prevention, treatment, and promote mental health and well-being. Do you think we can achieve this? And if so, why or why not? Okay. And the third question was, hearing or seeing the National Integrated Cancer Control Strategic Plan, what do you think are the other areas that we need to consider for the strengthening of the National Integrated Cancer Control Program that has not yet been said? Okay, so with that, what we will do is go through our panel speakers first. So the first pass will be, what are the main points that you would like to make to contribute to the discussion this morning, to focus on all the other questions? We will start with DOH first. So Dr. Beverly Lorraine Ho will be given the floor. Dr. Bev. I don't see her also. So if Dr. Bev is not here, can we start then with Dr. Rabindra Abiyansinghe, WHO representative in the Philippines World Health Organization. Dr. Ravi?
Thank you, Dr. Lorenzo, and very good morning to everybody. On behalf of WHO, let me thank the Department of Health and all the cancer control stakeholders for arranging this first Cancer Control Summit, Stakeholder Summit, with a special focus on childhood cancer in the Philippines. I want to start by congratulating the Department of Health now that we have a national integrated cancer control strategic plan that actually represents how the Philippines will achieve the goals of Republic Act 11215 or the National Integrated Cancer Control Act. WHO is aware that cancer is a growing public health problem affecting many countries, including the Philippines. Late-stage presentations of cancer and lack of access to diagnosis and treatment are common, particularly in low and middle-income countries. Comprehensive treatment is reportedly available in more than 90% of high-income countries. But demonstrating global inequity, it is less than 15% in low-income countries. Approximately 70% of deaths from cancer occur in low and middle-income countries. About 1/3 of the deaths from cancer are due to tobacco use, high body mass index, alcohol use, low consumption of fruit, vegetables, and high fiber diet, and of course, lack of physical activity. The economic impact of cancer is significant, and unfortunately, about 5,000 of these new cases are in children. In the Philippines, the projections are that cancer cases will increase by up to 78% annually and probably reach around 275,000 cases annually by 2040. Treatment coverage remains low, estimated at around 7% in 2020, as from the DOH's Medicines Access Program. Cancer control is something that WHO supports to address the growing burden and achieve the targets of premature mortality reduction from non-communicable diseases as set out in WHO's Global Action Plan for Prevention and Control of NCDs. And of course, as you mentioned, to achieve Target 3.4 of the 2030 United Nations Sustainable Development Goals. The key mission of WHO's work in cancer control is to promote the national cancer control policies, plans, and programs that are harmonized with the strategies for NCDs and other related health outcomes. I want to talk about childhood cancer also because more than 400,000 children are diagnosed globally with cancer aged between 0 and 19 years. Most of these children live in low middle income countries where treatment is often unavailable or unaffordable. In this respect, I want again to salute the efforts of the Philippine government and particularly the Malasakit initiative, which we believe will help reduce the economic cost to affected individuals and families. As a result, approximately 20 to 30% of children with cancer in low and middle income countries survive. This is in comparison to more than 80% in high income countries. And this, we believe, threatens the attainment of universal health coverage, both here in the Philippines and globally. WHO, in response to this, in 2017, the World Health Assembly passed the resolution, Cancer Prevention and Control in the Context of an Integrated Approach, that urges governments and WHO to accelerate action to achieve the targets specified in the Global Action Plan for Prevention and Control of NCDs and the 2030 UN Agenda for Sustainable Development to reduce premature mortality. In September 2018, WHO launched the Global Initiative for Childhood Cancer, following the third high-level meeting on non-communicable diseases at the UN General Assembly. The goal of the global initiative is to reduce the suffering of children with cancer and save lives, reaching at least 60% of survival rate by 2030. In recognition of universal healthcare's intent to strengthen the health system, the global initiative aspires to enhance countries' capacities by providing quality service, sparks action to prioritize childhood cancer nationally. The initial focus will be on 6 common cancers, namely acute lymphoblastic leukemia, Burkitt's lymphoma, Hodgkin's lymphoma, retinoblastoma, Wilms tumor, and low-grade gliomas. These cancer types are common in the Philippines. Among other support that WHO provides to DOH for cancer control, the Philippines has been selected as one of the focus countries for the global initiative on childhood cancer. Indeed, it is the only country in the WHO Western Pacific region identified for this support. While the National Integrated Cancer Control Strategic Plan is developed to support the operationalization of the NICCA, it's timely that global initiative and NICCA share the goal of scaling up capacities to bridge the gap and address the unmet needs in childhood cancer. What is different is that early diagnosis and treatment of childhood cancer usually enhances survival and the quality of life of children and reduces their pain and suffering. While in the case of adult cancers, we have a lot of work to do in the prevention sphere, reducing exposure to carcinogenic substances like tobacco use, alcohol use, healthy lifestyles. So the focus is both on improving the prevention aspects and also the early diagnosis and appropriate management and access to management, appropriate management for adult cancers. In collaboration with the WHO, with the Department of Health, we are supporting the strengthening of health systems at national and local levels to improve access to cancer care. Increased political commitment for cancer prevention and control is important, and WHO applauds the efforts of the national government and the local government units in their efforts to strengthen these through the various national strategies, action plans, and frameworks. WHO supports the coordination of DOH's research and innovation mandate to provide national policy direction and develop national plans, such as the development of the DOH Cancer Research Agenda and the establishment of the Philippine Cancer Center Scientific Research Data Center. As part of the work for the Global Initiative on Cancer Registries, support the monitoring of cancer burden through the project assessment of cancer registries and development of guidelines for cancer registries, and identifying best buys, developing standards and tools to guide the planning and implementation, etc., etc. So in a nutshell, WHO is very, very committed, and this first stakeholder summit is a step in the right direction. WHO is very pleased to be part of this effort. We urge the national government, the private sector, other stakeholders, and civil society organizations to continue to engage, to spread the word, and to support the efforts to increase awareness, to strengthen the prevention aspects, to promote healthy lifestyles, especially more important in the current context of the COVID-19 pandemic also, but also especially aligned to the theme of this summit, to particularly strengthen the access to diagnostics and management of childhood cancers, thereby allowing them better survival, survival free from pain and suffering. This is critically important for all of us, as many of us as parents who have children. So I urge all of you to come together, making use of this summit as a pivot to galvanize and accelerate action. Thank you very much for the invitation. It has been a pleasure to join this panel.
Thank you very much, Dr. Rabi, for your call from the WIPRO and from the country WHO office. Now we will move to hear from some of our ardent advocates for cancer control, members of the National Integrated Cancer Control Council. I'd like to start with calling and giving the floor to Dr. Corazon Nelangel, a member of the National Integrated Cancer Control Council and also the president of the Philippine Cancer Society. Ma'am Cora, please.
Thank you for having us join you today in this very important summit, particularly since we are starting to implement the NICA law. So you gave us 3 questions, and I think I'll go there already.
Yes, ma'am.
So, okay, so the first question is, from the lens of the offices or institutions that I represent, and considering the status of implementation of the NICA and the unmet needs of people with cancer, which specific area do I think the country should focus on? Now, before I give what I think, please allow me to say this first. It has been a privilege and an honor to have been part of the control of cancer in the Philippines from 1986, Secretary Bengson's DOH Cancer Task Force, and then Advisory Cancer Control Council up to the time of DOH Secretary Riodica. And now this 2021, the NICA Council. 35 years of patience admixed with frustrations, but also gains, although small bits at a time. So I represent 35 years of struggle against cancer, representing several institutions, really. Academe, oncology specialty profession, government and private cancer centers and clinics, oncology-focused civic society, and patient support groups, reflecting the specific areas I think the country should focus on. Now, last year, 2012, a summit but of a smaller focused audience gathered pondering on a similar theme to strengthen the control of cancer in the Philippines, rising up to the future we want, similar to what you have now. And I said we can only be able to do so if the Philippines has a cancer control law. Since government and DOH have issuances on cancer control, but this did not really have teeth at all. And here we are now. We have the NICA law. Perhaps now we can gather these cancer control bits and pieces, these issuances and packet activities we have been doing for the past years and put them together as an organized and planned whole. So what specific areas do I think the country should focus on? The Universal Health Law will complete the NICA on primary, secondary cancer control of cancer, health promotion, cancer awareness and literacy, cancer screening. Well, if we can't afford the honest to goodness cancer screening, downstaging, early diagnosis, as Dr. Ilbawin, I think, did say a while ago, which begins in the community, embedded but must now be emphasized in the LGU's health promotion campaigns, the PhilHealth's Consulta, and the comprehensive outpatient benefit program, among others. Secondly, We have now on the ground cancer facilities across the country doing tertiary cancer prevention and palliative hospice patient care waiting to be upgraded in quality. These are NICA medicine and treatment access sites. The oncology specialty societies have been ready to up the quality of these cancer centers, which are also waiting to become an officially mandated Philippine network of cancer centers, sharing expertise, experience, patients, resources, researches, continuing quality development. And again, this is upping service coverage. So the first one really is awareness, and then screening, downstaging, and then now upping our service coverage. The various government facilities, the ILG, the OLE, DepEd, the SWD, PhilHealth, FDA, have since in place something for the cancer patients and now must also scale up according to the NICA provisions. Now, thirdly, we need quality cancer information through population-based registries, support the current in Metro Manila, and expand to Region 1 CAR, Metro Cebu, Metro Davao, and cancer researchers, without which we are blind in assessing the strength and opportunities we currently have and will have across the years, and what gaps and weaknesses we can resolve. This will answer how are we doing? So that's the first question you wanted us to answer. I go to the second. Okay, the second one really is the UN SDT 3.4.1 aims to reduce by 1/3 premature mortality from non-communicable diseases. That includes attributed deaths from cancer through prevention treatment among LMIC, reduced by 20%. So do I think we can achieve this? Do I think Philippines can achieve this? First, note that the UN SDG 3.4 is earmarked against the period 2010-2030. 2010-2030, a 20-year implementation period. We are not in 2010. We are past 2010. And the NICA is just starting to be implemented this end of 2021. Still coming up with enabling DOH and other government issuances to be able to implement the law. Now, the 2021-2030 National Cancer Control Strat Plan goal states that by 2030, provided cancer control services to at least 50% of all Filipino cancer patients, improving their quality of life, and reduced overall mortality for cancer by 10%. 2021-2030, an 8 years implementation period. Quite a task, really, but I think we can achieve this. Since the oncology, specialty, and civic societies and the community patient support groups are passionate about their rules in this. However, more importantly, necessarily and urgently so too must government. Government has to transcend silos, take the lead, and likewise be passionate about this, be true and fast and furious. So the third question, hearing and seeing the National Integrated Cancer Control Strategic Plan, what do I think are the other areas we need to consider for the strengthening of the National Integrated Cancer Control Program? The NICC strategic plan for a period 2021-2030, just 8 years, about just 8 years, is full to the brim. We could not do this at all if the DOH Cancer Control Program is stuck under the layers of the other DOH NCD programs without a line item budget of its own. If the DOH Cancer Control Program every year has to fight for a share of the NCD budget, not knowing if it could be given a share at all.
Dr. Nalanghel, you were muted. I think
where am I? So,
last two sentences po.
Okay, so I said something like, I said that we cannot do this at all. We cannot, we cannot implement the NICC strategic plan 2021-2030 is full to the brim. We cannot do this at all if the DOH cancer control program is stuck under the layers of the other DOH NCD programs without a line item budget of its own, if the DOH cancer control program every year has to fight for a share of the NCD budget, not even knowing if it could be given a share at all, considering too that the COVID-19 pandemic has unleashed an unprecedented worldwide health and economic crisis with the world's most vulnerable countries, such as our country, affected the most. Otherwise, yes, we could do many of the NICA strat plan activities even in just 8 years, as long as the implementation of NICA is, as is written, is supported by resources, backed by a separate line item and DOH budget over the coming years, knowing our limitation and then prioritizing. So that's it, the 3 questions and the 3 answers.
Okay, thank you very much, Dr. Nalanghel. We'll get back to you during the discussion part. Okay, we will go back now to DOH. So we would like to call in now our panelist, Director Beverly Lorraine Ho, Director 4 of the Department of Health. Back to you, Bev.
Good morning po, and good morning to all my co-panelists and my former teachers po. Magandang umaga po sa inyong lahat and to all our partners in our cancer portfolio or advocacy. I think from the DOH's end, it's very clear that the shift in the, as prescribed, both in the cancer law and the UHC, should allow us to put in a lot of effort into multi-sectoral work that will be required for a more effective health promotion and disease prevention campaign. And when we talk about campaign, it doesn't have to mean the typical way, that which we talk about health promotion, which is to put out information and brochures, etc. But actually to put in solid infrastructure in schools, in workplaces, and in homes where people stay for longer periods of time in order for the risk of the people to be significantly reduced. So if we talk about diet and lifestyle risk for cancers, then it shouldn't just mean making people aware of what they need to eat or what they don't need to eat, but having multi-sectoral collaboration in order to ensure that the healthier diets are actually more affordable and that the healthier diets are available in the community marketplaces, for example. If we talk about practicing a healthy lifestyle, which encompasses both physical and mental health, we need to talk about good workplace habits or workplace atmosphere and infrastructure, but also say an environment that allows for people to really practice healthy lifestyle. So we've begun, and those are some of the perhaps positive things that came out of the pandemic, is realizing that people can't walk or bike to work because it's just so difficult to do and so unsafe to do. So I think that's on top of our prevention work like immunization, and our Cancer Council has been very vocal about scaling up our ability to vaccinate. And year on year, we know that our best performing years, we would really just have around 70% of every birth cohort fully vaccinated. So on that said, it will also be critical. I do agree with the points raised by Ma'am Cora that funding is critical. So the prevention part is often, as you would know, Ma'am Feli, the hidden hand, diba? People usually wouldn't appreciate it because it's not so much the gut issue, no? Parang long brewing siya. Pero yung gut issue is being able to get support and financial protection. Di mo kailangan i-worry yung financing, no? Both for screening, repeat testing, and even treatment. And so with the guidance of the council, we had requested back, no, for that line item budget, and in fact, even a huge, larger chunk of budget, not to just cover medicines, which are currently in our access programs, but even diagnostic. The National Integrated Cancer Control Strategic Plan, I think we should be proud to say that it was a product not so much just of DOH work, no, but largely led by our cancer experts, cum advocates. No? So parang people-led siya talaga. So the question now is what the key areas that we need to focus on. Well, apart from making sure there's money to run it, I do agree that we will also need a very good information system. And this is something that perhaps, again, each vertical program would probably want to have their own robust system, but we would want to try to make sure that as we build the various vertical information systems, in a way we actually don't burden the primary care providers. No? Because probably the oncologist can submit their data to us, but we will likely need yung earlier part, no, ng history ng patients, and it will be the primary care providers who will do it. Yeah, I guess the last points lang that I would have is sabi nga ni ma'am, no, we have to get out of the silos, institutional silos, not just among government agencies, but within the DOH. No? It's a maze in itself. Alam niyo po yun, Ma'am Feli.
Yes.
And I think we have been very, very lucky with our set of Cancer Council experts because they're really pushing us to work beyond the typical boundaries, and the urgency at which parang they are pushing us is also very much appreciated, considering na everything is important, di ba? But of course, if walang tututok at walang mag-project manage, mas mahirapan tayo and mas matagal yung output. Perhaps I just like to end there and say we have so much to do. We will need everyone to help each other out, but also clearly recognizing the importance of fair critique that will allow us to do our jobs better. You know? So we will really appreciate honest feedback, and so that's really how we are going to be improving. So yun lang po, we will continue to keep communication lines open, and I would really say that then NICC Council is one of our most intimate intersectoral councils that we have in terms of the guidance that we're really getting from them. So yun lang po. Maraming salamat, ma'am.
Thank you. Thank you so much for those views. That was right on point, as Dr. Nilanghel specified, that the cancer warriors, experts and advocates are already doing their part, but they need government, very responsive government support to implement NICA more meaningfully. So thank you for that. We will go to our other NICA council member. Dr. Rachel Rosario is the Vice President of the Philippine Society of Hospice and Palliative Medicine, representing cancer survivors. Being one of the ardent supporters and advocates for cancer control, I give the floor to you, Dr. Rosario.
Thank you, ma'am, and good morning to everyone. I would like to answer the questions that were given to us earlier from the perspective of the hospice movement, and of course, on behalf of the cancer support groups that I am a member of. And I think the first question was, which specific area do you think the country should focus on? And it is with much passion that I will say we need to give a look at palliative care. We do know that supportive care, hospice, and end-of-life care, including survivorship care, will be under this banner of palliative care. And sad to say that in this country, we still need the manpower, the resources, and even the training that we hope to correct soon for instituting palliative care. Now, our Globocan statistics as of 2020, we do know that there will be 153,000 or more new cases of cancer, and 92,000 and more will be losing their battle against this disease. And at any one time, there will be around more than 350,000 if you're going to look at the 5-year prevalence rate. So you can imagine how much palliative care can help, no? Cancer patients, we do suffer from the moment we are diagnosed, whether it's physical, whether the suffering is emotional, whether it concerns mental health, whether it's social. You go into a different world when you are given the diagnosis of cancer. So palliative care, psychosocial support, addressing the physical symptoms, there will be pain, there will be nausea and vomiting, there will be a lot of complaints. We want improved quality of life for our patients. We do note that The Economist at one point had a study on the death index, and they listed the worst countries to live in, no? If you were to die, and unfortunately we were, at the very top of one of the worst countries to die in. And basically, the recommendation was that we had to up our game as far as palliative care is concerned. So that would be one of the things that I think we should really concentrate on, aside from all the other important priorities of the NICA. And do you think we can achieve the target for the SDG that was set for us to reduce by 1/3 premature mortality from non-communicable diseases? And well, of course, this includes the deaths from cancer. I guess we can really make a dent on this. We do know that time is running short, and we started the game late. If we were in a race, we started the race late, but we can still do something about it. I would probably say perhaps one of the achievables will be in the field of reducing death rates from cervical cancer. We know that this is one of the diseases wherein we can catch the precursor stages. Cancer may not yet be there, but it is a pre-cancer stage, and we can already do something about it. Now, there's another question, and this is the last one, on the consideration on what should we strengthen in the NICA control program. Speaking again not just from hospice, or not just from the point of view of survivors, but also from the Philippine Cancer Society as executive director and having one of the viable population-based cancer registries in the country. And I think we should also support very strongly and strengthen the population-based cancer registries, as well as the other registries, because data reigns supreme when we are about to start programs. And we need this not just to know our starting point, but also to monitor and do surveillance on what we are doing with our programs, and the record if we have been achieving our goals. As far as patient support groups are concerned, there is only one cry from almost all of us, and that is funding and support. This is very crucial to survivorship. This is very crucial for our screening, early diagnosis, and treatment. We are appealing to everyone, legislative body, the Department of Health, that the Cancer Assistance Fund that has been allotted for patients should be there, and whether there are benefits that can be given for us by listing us as one of the beneficiaries of the PWD Act, then we would also appreciate that very much, and I think that's going to come very soon. Now, anything else from, I guess, even before diagnosis is being done, screening again, as I mentioned it, even vaccination, I think we have to give priority to this. And this will hopefully also bring down the rates on cervical cancer and liver cancer. So with that, I close my argument for the day on behalf of the hospice movement and cancer survivors of the Philippines. Thank you.
Thank you, Dr. Rachel. We will get back to you when we go to the discussion part. I just wanted to say that later on we will interact with our audience. Dr. Alvin Marcelo, Eloy has already been saying to both Dr. Rachel and also Doc Bev that there is already something in place for the information system and the cancer registry that may be used. So we'll ask him about that after we get all the panelists finished. We'll now go back to DOH. We have a panelist from the FDA, representing the FDA. We have Dr. Oscar, representing Dr. Domingo right now. Dr. Oscar Gutierrez is the Deputy Director General of the Food and Drug Administration of the DOH. So, Dr. Oscar, can we hear from you now? Unmute, please. Great.
Okay. Maraming salamat po, Dr. Lorenzo. Magandang umaga po sa lahat. As far as the FDA is concerned, we will focus on ensuring early access to essential medicines, including innovative medicines and health technologies for the diagnosis, prevention, treatment, and control of cancers to ensure highest possible chance of survival among people with cancer. It will include quick access to drugs and vaccines for compassionate use and emergency use. We are already automating our systems. We are developing an online system on product registration to ensure faster turnaround time for our CPR applications. I am happy to inform you that the Secretary of Health already signed Department Order, Administrative Order number 2020-0045 on facilitated registration pathways and DOH-WHO number 2020-0044 on adoption of the WHO collaborative procedure for accelerated registration. This AO will be the basis of the FDA issuance to provide regulatory recognition and reliance mechanisms as basis for developing the online system to significantly cut the turnaround time to less than 120 days. The FDA will also continue to upgrade its science-based and evidence-based regulations of health products. That includes not only drugs, but food, medical devices, cosmetics, and household hazardous substances. We will be vigilant in order to guarantee safety, efficacy, and quality of medicines and medical devices at the points of use in clinics, centers, hospitals, by implementing good storage and distribution practices along the drug supply chain. We will collaborate with other government agencies and the industry sector to ensure competition and make the price of medicines for cancer affordable, if not reasonably priced, and if possible for free. And aside from streamlining and automating our process for product registration, there are other areas that the FDA can strengthen, and that includes networking with the hospitals and drug outlets to make sure that these medicines are properly handled and stored. We will enhance our close collaboration with the DOH and the drug industry to investigate reports and complaints on overpricing and even adverse drug reactions. Should there be reports on counterfeiting and illegal online sales, we will be partnering with law enforcement agencies not only at the national level, but also at the local level. Thank you po.
Okay. Wow, that was a very rapid response to the appeals to make cancer treatment affordable from the FDA. Later, we will hear from, or maybe we should call our representative from PhilHealth as the concern for lowering the cost of care for cancer patients and their families has been poignantly aired all morning, even yesterday in the pre-summit. Okay, so for the PhilHealth, we have Dr. Risa Mahela Herrera, Acting Vice President of PhilHealth's Quality Assurance Group, to give us the views of PhilHealth. And I'm sure, Dr. Herrera, you've heard about all the passionate pleas for financial support. So please, Dr. Herrera.
Thank you for the opportunity po for inviting us to the Cancer Summit. And as a financer and a strategic purchaser of health services and health goods, PhilHealth would want to cover the entire spectrum of care to ensure that Filipinos will be productive and be able to access the services, if possible, at the level of preventive care. We understand that there have been several initiatives already on cancer and even other services or conditions in the Philippines. And what we would want, what PhilHealth would want is for the community or the environment to be enabled to purchase the services, the environment to be enabled to for the Filipinos to access the services, and the environment to be able to provide and sustain the services that are needed. So with that, what do we need to enable? We need the screening services, of course, to act on impending conditions early. So for screening, are the training for screening available? So this should be in place, and it should be accessed. It can be accessed by our practitioners nationwide. The current dilemma is there are training programs available, but it cannot be accessed by the regional offices. So right now, siguro, especially the dawn of the pandemic brought us to virtual meetings and programs. Probably we could provide the screening programs, the screening trainings virtually and increase the access, increase the capacity of our healthcare providers in detecting early for cancers. Now, aside from providing the screening, the training programs, there should be available health practitioners in the regions or in the even in areas na especially in the municipal levels. So how do we entice them to practice in those levels or have a mechanism of enabling the health facilities, enabling them to secure or access services for screening. Uh, it may be that ang hurdle to overcome is should it be face to face or does the screening allow sharing of information or pwede bang how can we maximize telemed if there are very scarce na supply of healthcare providers that can um, give the services and um, uh, so probably simplifying the trainings or simplifying the screening services that even our rural health units or workers in the barangay level can be utilized or can be um, recruited to do the screening services. So enabling the environment. Another thing is on the treatment side, um, we have identified the modalities of treatment and very expensive ang majority of the uh, drugs for cancer. So how do we bring down? How do we bring down the cost of treatment? How do we collaborate and ensure that kasi even if we have the financing arm, we should ensure that the financing arm could sustain uh, paying for that treatment. Kasi sayang naman if we start out well and then hindi naman pala kaya ng funds. So we continue to negotiate and ensure that we bring down the rates of the services and the medicines or treatment modalities that are necessary in each step of managing cancers. Another thing is on messaging. How do we deliver our messages on prevention and on early detection of cancers? It should be simple enough and it should not scare our potential patients, but it should encourage them to seek medical assistance, no, for them to ensure that it will not progress or conditions shall be addressed early. Then from messaging, if the on treatment naman po, on management, we could establish multidisciplinary teams, at least at the regional level, and probably spread it out in areas where it can be accessed by the population, not purely on the highly urbanized setting. Usually, deprived talaga yung malayo sa health facilities. So how do we bring it down to the like the GIDA areas, and how do we ensure that things will progress or things will be sustained? So, in a perspective of finance purchaser of health services, it's on sustainability and ensuring that what we will be paying is what we will be paying for is of adequate quality, and it would redound to good outcomes and an acceptable level of managing the conditions. So with that po, I turn it over to the next speaker. Thank you very much.
Okay, thank you very much. In the second round, Dr. Herrera, there were 2 points that were raised earlier and also in the chat box. One was, is PhilHealth ready to expand benefit packages to support cancer? And second, maybe one of the most useful investments of PhilHealth right now will be to support and finance telemedicine. So in the next round, maybe we can ask you to say something about those. Okay, let's move now to our partners from the legislative branch of our government. No, we're very fortunate to have the COMSEC, the Committee Secretariat on Health here, a long-time member of the Senate and working on health. Ma'am Beatriz Abet Chonco Cruda, a long-time ally from the Senate. So Abet, what do you have to say to us this morning in support of the NICA?
Good morning, ma'am. It's good to see you again, Dr.
Yes.
Lorenzo. Long time no see po. Good morning po sa lahat. And we are happy to be part of this summit. And if I remember, we passed the National Cancer Control Law in the 17th Congress. And the staff of Senator Go, who is also with us, Jod, was also a staff of Senator J.B. Ejercito, who was the sponsor of the National Cancer Control Law. So for the questions, I'd like to focus on the first question, ma'am. It was from the lens of the institution that I represent, which is Senate of the Philippines, which unmet need or specific area of the national cancer control should the government focus on? So I share the views of the previous panelist, Dr. Ngel Angel, that it should be Ngel Angel. The government should focus on increasing public sector spending on prevention, promotion, screening, and early diagnosis, and reduce the financial burden of the patients and their families. On the part of the Senate, we have passed actually enabling laws to make this goal a reality. These laws provide a policy framework, and namely, we have the UHC, which optimize and increases the financing, the public sector's financing for healthcare services. The DOH to focus on the spending on prevention, health promotion, and population-based services, and for PhilHealth to focus its spending on individual healthcare services. And the overall goal of this is to reduce out-of-pocket spending of individuals and families. And then the UHC law also seeks to have an integrated local health system that will capacitate LGUs to provide healthcare services. And it also has a provision on health promotion, allocating 1% of the total DOH budget. Perhaps this is one area we can look on and increase this allocation for health promotion. And then we have the Malasakit Center Act, which provides a one-stop shop center to provide access to medical and financial assistance to indigents, as well as financially incapacitated individuals. So cancer is a catastrophic disease that even if a patient is not and indigent. It incapacitates financially individuals and their families. And I would like to highlight the importance of strengthening and the full implementation of these two laws, aside from the National Cancer Control Law. And if there are other areas that in the National Cancer Control Program, and to ensure its full implementation, as well as the UHC, we are more than willing to give our support to have full and strengthened implementation of the National Cancer Control Law. And the panelist from PhilHealth, Ms. Riz Herrera, pointed out the need to maximize telemed. We actually have a pending legislation, a pending bill in the Senate to regulate and institutionalize e-health. Dr. Neil Angel also pointed out the need for a separate line item for cancer control program. And we have Jod here, the staff of Senator Go. This is something we can take note of because Congress is in the process of budget deliberations. So yun po, ma'am. Thank you. We give our commitment to helping the group, the advocacy group, in strengthening the implementation of the National Cancer Control Law.
That's great. That's great news, Ma'am Abet. And we'll get back to you. I think there are also some questions for you. And there's a big thank you from Dr. Nelangel already for now. Let's move to our last panelist, Mr. John Carlos from the Office of Senator Bongo, to shed light on his views, specifically from the Malasakit law perspective and how it will contribute to NICA and the priorities that should be focused on. Thank you. To you,
Yes.
John.
Yes, ma'am. Good morning to everyone. First of all, our office and Senator Bongo would like to congratulate the Department of Health and WHO, as well as the organizers of this summit po. So I would like to focus on the first question. First po, one of the priorities of the Committee on Health is to ensure sufficient funding for the NICA. So for the 2021 budget this year, Senator Go pushed for additional budget for the National Integrated Cancer Control Program, particularly for the procurement of additional drugs for cancer medicines. So we were able to add 500 million in the 2021 budget for this. Aside from that, ma'am, we were able to add additional budget of 120 million for the Cancer Assistance Fund. This is for the assistance for the treatment of cancer patients. So for 2022, we are giving our commitment that we will try to push for a separate line item for the cancer budget. Since the budget for cancer, I believe, is included or is lodged under the non-communicable diseases budget. So we will try to have it separated from the NCD and have a separate line item for this. With regards to the Malasakit centers, ma'am, assistance for cancer patients can also be accessed through Malasakit centers, not just financial assistance, but as well as other assistance given by the Malasakit centers. The Committee on Health passed Republic Act 11463, or the Malasakit Centers Act. And for the information of everyone, the Malasakit centers have three functions. First is health promotion, second is patient navigation, and third, the financial assistance. So firstly, the Malasakit centers can help or can assist in the implementation of the NICA through its function on health promotion. So since it is provided in the NICA that the DOH shall intensify its cancer awareness campaign, Malasakit centers can help in that, since it is provided in the law that Malasakit centers shall provide critical information on healthy behaviors and conduct health promotion activities in the hospital. Second, ma'am, another concern I believe is the proper referral of cancer patients. Malasakit centers can help in that as well, because Malasakit centers have a patient navigation function so that the patients can be guided in the healthcare provider network. And of course, lastly, the most famous function of the Malasakit centers is financial assistance. So the cancer patients can access financial and medical programs of 4 agencies in the Malasakit centers: DOH, DSWD, PCSO, and as well as concerns on PhilHealth membership and package rates. So that's it, ma'am. So with the 3 functions of Malasakit centers, again, patient navigation, health promotion, and financial assistance, this is well harmonized with the objectives of NICA, so that we will be able to fully assist cancer patients.
Thank you. That was a very clear cut discussion of what the Malasakit Center can contribute in terms of the priorities. I understand, though, that we have someone from the Malasakit Center themselves. We have Director Angeline Del Mundo, represented by Ms. Alison Umandap. Can you kindly add to what John just specified, or is there anything else that you would like to contribute to the discussion? Alison?
Good morning, everyone. I would like to congratulate for the DOH and the WHO for a very successful day 1 of this summit. And also, I would like to convey our heartfelt gratitude for always inviting the Malasakit Program Office, being the forerunner of the Malasakit Program and the operationalization of Malasakit Centers nationwide. Well, just to add lang po sa binigay ni Sir John a while ago, we manifest our intention to really help the cancer control program po for its implementation all throughout the coming years po. And with the enactment of Republic Act 11463, also known as the Malasakit Centers Act of 2019, the Malasakit Program Office will definitely help po the cancer control program sa lahat po ng endeavors nila na makakatulong kami, especially when it comes to the provision of medical and financial assistance. It is true that right now our goal po is to establish Malasakit centers in all DOH hospitals nationwide, and not just in DOH hospitals, but our intention is to include military hospitals or DND hospitals and LGU hospitals po. And being a one-stop shop, we will definitely develop more ways of providing more services po sa ating mga kababayan, lalong-lalo na po ang mga cancer patients natin nationwide. Yun lang po. And the Malasakit Program Office and Malasakit Centers are always open po. And we've been continuously being invited po ng cancer program sa lahat ng kanilang mga orientations before. And we manifest to continue to do that po for the next coming years. Thank you so much po.
Okay, thank you for that very valuable addition. We will be going into the second round before we open to the Q&A with the audience. But first, I'm being tasked by the organizing committee to have a photo op because we might be losing some of the speakers and the panelists. So may we request all the panelists, guests, speakers to please open their video, including those from earlier, our reactors, commentaries, and our keynote speakers, if you're still here. Dr. Ilbawi, are you still with us? We'd love to have you in the picture. Okay, I think that's everyone that already responded. Okay, team, who's taking the picture? Jose?
I'll be giving the cue na lang po. Kindly keep your cameras open po. 1, 2, 3, smile. So we have another slide here. Keep your cameras open. 1, 2, 3. Smile. Thank you, everyone.
Just keep smiling.
Over to you. Yes, po. Over to you, Doc Lynn.
Okay. So in our second round now, if you have anything to add to what you just said, I just wanted to get a fresh view, a short view from everyone. It looks like since the NICA is already here, our attention is focused on its effective and efficient implementation. That's what everybody's been saying, and everyone that's been asking questions about that. In fact, even before the Q&A, in the discussion, one question that was asked by a participant was this: paano humingi ng tulong sa gobyerno ang taong may sakit ng cancer gaya ng adult lymphocytic leukemia, ngayon wala pang PhilHealth guidelines or support? So maybe we can ask Director Bev to respond from the DOH side. Ano-ano ang mga tulong na pwedeng ibigay ng gobyerno ngayon at wala pang PhilHealth support na maaasahan?
Thank you, ma'am. So I think currently there are only 2 available mechanisms, and that would be through the MAIP or Medical Access for Indigent Patients program, for which you can access it through the Malasakit Center, in the various DOH hospitals. And if in case the patient is in a private hospital, there are Malasakit centers in the government hospitals that actually link up with those private hospitals. The second is through the medicines per se. So yung kanina po is services, so that would probably include diagnostics and other fees in the hospitals. Pero kung medicines po, I think it was also mentioned in the sessions yesterday and today that there's a cancer assistance fund for medicines, di ba? So meron po tayong mga binibiling gamot. Again, they're only limited to certain access sites. And so in case that the medicine for that condition is being bought as part of the program, then magagamit nyo po yung gamot. So it's either the service with the Malasakit and the MAIP or the actual gamot, na libreng gamot.
Okay. And this is available both in government and private hospitals, Doc Bev?
Yung gamot po is largely in government hospitals, which are access sites po.
Okay. But the link for services between public and private hospitals is there?
Opo, for the Malasakit po.
For the
Kasi
Malasakit.
po lahat ng private, nakaset up na po ng Malasakit. So some of them have MOA with public hospitals po.
Okay. Okay, so let's go to our second round then, but mostly focusing on implementation now of NICA and the priorities that you mentioned. Dr. Nalanghel, is there anything you'd like to add to your list of priorities?
None really, unless you have any questions.
Oh, okay. There are, there are questions later on, but also for PhilHealth. Doc Rachel, anything to add?
I guess I'd like to see the Philippine Cancer Center already well established. That's a wish list for 2022, or perhaps if we can do it for the last quarter of 2021.
Okay. Okay. So thank you. Okay, I think with that we're ready, and it's time to move to our question and answer portion. The first question from Cara Alikpala is this: for PhilHealth and DOH, can you consider taking out the virgin case requirement for the Plan Z packages? It's a big obstacle to access, and this has been a long time plea of patient groups. Kindly advise regarding this issue. So DOH first and then PhilHealth?
I think it would be better for PhilHealth to answer that because it's their guideline. Doc Reyes.
Okay, Doc Reyes.
Thank you, Doc Bev.
PhilHealth will always be ready to take any challenge. No, kailangan lang po is the complete staff work and that the modalities are available nationwide. And we need help in mapping out saan ba ito ma-access and can this be sustained. Now, coming up with a design of a package does not end there. It has to be approved, of course, by the board, and it has to be accepted by the implementers, the one that will be delivering the services. So we have our Z packages since 2012, and it has been ongoing and it will be adjusted. I think by the end of the year, meron na silang certain Z packages that which the rates will be adjusted. And I don't think coming up with a Z package for each cancer is sustainable. I think it would be approaching the conditions holistically. So, working towards the DRGs and costing the services and the modalities of treatment properly would allow the social health insurance to support the financing arm uh, for health for health for health. And that's the I think hindi dapat siya na come out with one package for this, another for this, but let's look at it holistically, integrate the screening programs in our primary care. Alin ba ang pwede nang magawa with the current resources in the municipalities. And then if this is not available in the rural health units, we come up with our specialty primary care packages. So ano yung services that can be referred and how can we establish these services para ma-access siya at the municipal level. Kasi what is important is that we ensure that the patients can access it in their residence or place of work para ensure we can ensure that the patient will avail of the program. Another thing is I mentioned earlier telemedicine. We have consulta. In the consulta we recognize telemedicine, but we do not yet offer support to telemed as how it is being used in the private practice, no, that we pay for each session of consult. In social health insurance, our approach to primary care is through capitation, and the payment to professionals or to services availed in the primary care facility should be an arrangement between the owner of the primary care facility and the ones that are working in the primary care facility. So I do not yet see that PhilHealth can support fee for service na telemedicine services, but in our eyes at present, it is a manner of delivering the services. So we can access that service, but we cannot expect yet that the fund can support a per consult na payment. Unless there is an existing robust information system in place that can monitor the services rendered and where are these services being availed of. So dapat in place din yan in the municipalities, and healthcare providers are capable of sending that information digitally. Otherwise, haywire talaga yan. Like right now in Consulta, we have very minimal, though we are almost in a one year implementation, because we require them to have a functional EMR system. Otherwise, hindi ho natin ma-evaluate yung program later on, and we cannot keep track of what we are paying for, and we cannot collect information efficiently to use later on in improving our packages. So we need that in place, functional information system na hindi lang din naman siya for cancer, but considering all the aspects of primary care. Para hindi din siya piecemeal na ito lang ang ma-address natin yung cancer, but what about the other portion of health, no? And what's important is we enable the smallest health unit to deliver at least the screening services para we could move forward and navigate these patients to the proper service provider. So enabling that setup and ensuring that the referral system and the information system support is operational. Thank you.
Okay, thank you. There's just a comment on the box in addition to this topic we're talking about, from Dr. Marcelo, saying that he thinks that telemedicine should be supported by PhilHealth not as a fee-for-service item, but as a flat fee. So something for you to think about. Another question, still from PhilHealth and later for DOH, from Dr. Alcasabas again. May I ask PhilHealth if we can also increase the annual coverage of cancer to 90 days, similar to what dialysis patients get, while Z packages are still under development?
I guess they are referring to radio and chemotherapy, the modalities for treatment. No? Right now in the pandemic, I think it is the annual limit is of 45 is lifted. So I think yes, because these are special privileges provided since March 2020. So covering for all the modalities, expanding it, I think it is no longer an issue when we fully implement universal health care, because sabi ng universal health care, everyone is eligible. Wala na tayong caps. Basta pumasok ka ng health facility, the social health insurance shall pay for your individual personal services. So, but that should also be coupled with source of revenue. Saan natin kukuha yung pang-finance niyan? Right now, we are not moving on the increase also of premium contributions that has been also in the law, because if you come out with additional packages, it would entail additional expenses. So to support that, we laid out in the universal health care a staggered increase in the rate of premium contributions. But this also did not materialize since the start of the pandemic. However, government has been providing subsidies naman, and probably we could work on integrating all the available na subsidies, like in the Malasakit Center, that we pull in all the funds and use a chunk of that to address the concerns that are highly material for healthcare, particularly in cancer.
Okay, so we have the wonderful news that the caps have been lifted because of the UHC regime, right? So I guess that's something that we should let everyone know. Okay, another question from Aurora Campita. While this was addressed to DOH, maybe the others can also chime in. How can DOH or others help our region, the CHDs, who do not have oncologists and are in geographically isolated and disadvantaged area like island provinces? Who would like to answer the question first? Dr. Nalanghel, yes, please.
CHD is what?
The Center for Health Development, the regional, the old regional health offices po.
Okay, and which island are you referring to?
She did not say which island she was from, but she was saying in behalf of all the JIDA areas who do not have oncologists.
Well, actually, in the chat box, I said something like the DOH training centers for oncologists can train your eligible doctor interested in oncology. That's why I wanted to know the area where they're coming from, because we can identify their hospitals and we can identify the capability of their hospitals and what the needs and so on. So this is actually part of the NICA law to up the services, particularly in the community. But we have to pair it off with the capability of the health infrastructure there. And perhaps we cannot put it up as soon as possible, but according to the condition of that island or that province or the town, we can build up, and we can network you with other cancer centers, basically that has been designated by DOH as cancer centers. There are about 24 general hospitals, DOH, across the country who have been identified as cancer centers and who have been identified to be upgraded as cancer centers. Now, that's a reason why I wanted to know, ano ba you, where are you, so that we can kind of locate you, and we can, yeah.
Ma'am, actually, our guest here who wants who was asking the question is here. Maybe she can be enticed to open her video, and she's been raising her hand. So Tricia Campita, can you please?
Yes, ma'am. I'm Dr. Aurora Campita from Mimaropa. So our region is Mimaropa, our CHD Mimaropa. They are all island provinces. They're composed of 5 provinces and 2 cities. And previously, I know that Dr. Cairo is giving medicine, anti-cancer drug in Hospital ng Palawan. But it's far from other provinces. So, yun po ang geographic situation ng Mimaropa.
Dr. Nalanghel, so that was Mimaropa, Region 4A.
4B, ma'am. 4B.
4B, sorry, 4B.
Well, yes, okay. So we kind of backtrack. What can we provide you for? I mean, I'm not really sure which, I'm not familiar with the place. Forgive me. But what I can say is that perhaps we can kind of do something in your place in terms of promotion, health, cancer promotion, cancer awareness, so that what we will do there, most probably because you are not really near a comprehensive cancer center, would be early diagnosis, cancer screening, and then you kind of come up with patients that can be transported to a place where they can be treated. Now, in terms of cancer drugs, kasi, it's very hard, it's very risky to bring cancer drugs to you and you'll be the one to administer it, because these are considered hazardous drugs, and hence they have to be under trained oncologists. Now, as I said, if you can identify eligible doctors in your place who we could train as oncologists, then we can do that, so that you will be equipped with doctors who can be able to give the drugs. Maybe even Dr. Ragasa is here, by the way, in the audience, I think. They can also train your surgeons if there's an eligible surgeon there for oncology surgery, maybe. And you need a radiotherapy machine, so maybe you cannot be given that because you are not identified as a comprehensive cancer center. But that's it. What we can do most probably is plan out a certain program for the community, and then linking them to specialized centers. Yes. Okay. I mean, is that? I hope we answered your question, but we can certainly. We are actually coming up. There's a UHC law which takes care of community. And the NICA law basically really concentrates more on cancer, but we can hook them together so that we can come up with a very good program for communities like you.
Ma'am, ano lang,
sa Region 4B, nearest will be Batangas. Batangas Medical Center is a designated cancer center. I'm not really sure if it's an advanced or basic, but it is a designated comprehensive cancer center. So if Dr. Cairo is in the audience, he could probably network you with Batangas Medical Center so that they can serve you well. They might even go to your place, look at your place, how it can be done, and so on. Hope that answers.
Thank you. Carmen Oste wanted to say something, but before that, I just wanted to say on chat that Dr. Ragasa was also saying that even NKTI and the other hospitals provide outreach services, like they have training for Batanes. So the island provinces are covered in some way, but it might have to be organized better. Okay, Ma'am Carmen, please. You have the floor.
I just wanted to say po, hati po kasi yung Mimaropa, from what we know from our patients. Half are able to go to Batangas, though it's a long travel. The other half po, sumasakay ng bangka, pumupunta po sa Kalibo, Aklan. So ano po yan, madami pong ganun po ang ginagawa. So the need is really there. So if we're going to assist in terms of the network, it's not just Batangas, but also Aklan. Yun po yung isa nilang pinupuntahan.
Okay.
Okay, ma'am, okay, thank you very much for the response. Thank you.
Sige. So I think we will be, as Dr. Nalanghel was asking Dr. Clar to probably provide some guidance on this, probably later, we can have you, Dr. Campita, get in touch with the Cancer Control Division also. Okay, we have lots of questions that just came up, but we need to wrap up. If you could kindly write your questions on the question and answer box of this Zoom. chat that we have. We will try and get back to you even this afternoon and get the panelists to answer some of the questions. We will forward this to them. But all good things must come to an end. And Partner Dali, we would like to give thanks to our panelists who joined us today. So you want to give them a big virtual clap in discussing a bold ambition to strengthen the National Integrated Cancer Control Program, rising up to the future we want. And surely we want to reach the bold ambition of reducing our cancer cases and first reducing the inaccess to cancer care. To sum up our dialogue this morning, we have some points to make. So from WHO and Dr. Rabi, he committed to the direction of providing quality of life care, especially of children with cancer. He urges all departments of government, civic society, and citizens to engage in awareness to cancer-related information. Dr. Corazon del Angel, on the other hand, specified that the laws, NICA and UHC now have teeth, and with the funding of these laws, she emphasized the need to cover the need to up the coverage of outpatient services by PhilHealth and to coordinate these pockets of activities for all to use, especially in the LGUs, and the need for quality information. There is also a need for cancer control to have its own budget. So Dr. Del Angel nicely brought out all those priority needs. Next, from Dr. Beverly Ho of DOH, she specified that health promotion efforts is not just in the LGUs, but also in schools and at home need to be done. We need a good information system to streamline all that is going on so that they can get honest feedback. And happily, Dr. Ho specified that DOH lines are open. So they're just waiting to assist in whatever communication needs there are. Dr. Rachel of the Palliative and Hospice Group said that training on hospice and palliative care for human resources and strengthening of the screening fund are the priorities right now. And they'd like to see this to fruition. Dr. Herrera of PhilHealth, on the other hand, specified that we need to make community enabled by having screening services available and done in the regional and municipal level by practitioners. Even LGUs can do it, and to deliver cancer prevention information for screening and early detection without scaring people need to be the priority. Next, please. More from Dr. Gutierrez from FDA. They have very wonderful announcements, including that they have already shortened the product registration and networking of pharmacies for good handling, hopefully to shorten the lead time for making drugs accessible. From Ma'am Beatrice Cruda of the Senate, she specified that we already have several laws in place, the UHC, the Malasakit Act, and NICA, and these are all the commitment of the Senate to cancer care. The budget time at the Congress is important to consider, and through this, they are putting teeth into the laws so that they are implementable. John Carlos from the Committee on Health, specifically, Committee on Health of the Senate, also gave us the news that they are requesting to add 500 million to the budget plus 120 million pesos to Cancer Assistance Fund for Medicines. For 2022 budget, they are seeking a separate budget for cancer care and not just as part of NCD. So wonderful news. Do we have any more, team? Okay, so that's it. So we've had a mix of wonderful news and announcements, as well as priorities identified to strengthen our ambition to strengthen the road to our ambition to strengthen the National Integrated Cancer Control Program. Thank you very much to all our panelists. And back to you, Dali.
Yes, Doc. Again, thank you very much to our panelists who shared their commitments and plans. It's very empowering to hear that we can win this endeavor against cancer. We would like to thank as well our participants who actively share their questions. And of course, our panel chair, Doc Lynn, thank you very much for moderating this very insightful and important dialogue.
Okay. And now we would like everyone to invite everyone to watch yung hinandang video presentation namin with the title Pag-asa sa Gitna ng Cancer. It's a
Ako po si Eileen Borbe, walang trabaho, single, 45 years old. Ipinanganak sa Tabaco City, Albay. Kasalukuyang naninirahan sa Santa Rosa, Laguna. Pansamantalang nanunuluyan sa Bakakay, Albay dahil sa nararanasang pandemya ngayon. Mahilig akong magluto, mag-alaga ng mga halaman, at photography. Matagal bago ako nag-decide na magpakonsulta sa doktor dahil sa financial problem. Mahal magkasakit at magastos ang gamutan. Masakit na sa katawan, masakit pa sa bulsa. October 12, 2013, nang ma-diagnose na may cancer ako. Stage 2, mixed invasive lobular carcinoma ang diagnosis sa biopsy ko. Pero sa modified radical mastectomy, umakyat sa stage 3A dahil sa na-delayed ng almost 3 months bago ako nakapagpa-mastectomy. Bago ako ma-diagnose, nagkaroon muna ako ng singaw na umabot ng halos 1 buwan. Ang tagal niyang gumaling. Nakaramdam din ako ng sobrang pangangate. Akala ko may buhok lang yung bra ko. Lumipas ang ilang buwan, bukod sa pangangate, kumikirot na, nag-iiba na rin ang kulay ng balat at may nakapana akong bukol. Kapag nahihiga ako, masakit ang breast ko at mahirap matulog. Kaya nag-decide na akong pumunta sa isang espesyalista. Bago ako magkaroon ng cancer, ang nasa isip ko lang dati ang magtrabaho para makatulong sa pamilya. Hindi ko nagawang mag-enjoy o pumunta sa mga party o mag-attend ng mga anumang okasyon. Umikot ang mundo ko sa trabaho at bahay. Kung iisipin parang ang seryoso at ang boring ng buhay ko. Ngayon, parang ang dami-dami kong ginagawa pero ang saya sa pakiramdam. Yung dating mahiyain, ngayon, parang ang dami-dami kong ginagawa. Pero ang sarap-sarap sa pakiramdam, ang saya-saya. Nawala yung pagiging mahiyain ko. Nagkaroon ako ng mga bagong kaibigan. Yung pangarap kong mag-volunteer sa mga charity, ngayon nagawa ko na. Yung tumulong sa mga homeless, sa tulong din at suporta ng mga kaibigan ko. Yung hilig ko sa photography, unti-unting nag-i-improve. Lumalawak yung kaalaman ko tungkol sa photography. Sumali nga ako sa mga photography group. Nagkakaroon naman ako ng mga award. Natulungan ako ng Philippine Breast Care Incorporated sa lahat ng gamutan ko. Simula sa libreng check-up, chemotherapy, mga medicines, mga laboratories. Ang Kasuso Foundation o ang Philippine Breast Care Incorporated ang nagdugtong ng buhay ko. Kung wala sila, wala na din ako. Hindi ko kakayanin i-shoulder lahat-lahat ng mga pangangailangan ko. Sila din ang nagbigay saya sa mga pasyente sa pamamagitan ng napakaraming activity mga sponsor na hindi nagsasawang magpasaya sa amin para asikasuhin lahat, mapasaya lang kaming mga kasuso patient. Para sa mga dumaranas ng katulad ng sakit ko na breast cancer, ang maipapayo ko lang, tanggapin nyo kung ano yung pagsubok sa inyo. Kung iiyak kayo, okay lang. Gusto nyong magmukmok, okay lang. Gusto nyong mag-isa, okay lang. Pero, pagkatapos niyan, bumangon ka, lumaban ka, at lumapit ka sa Panginoon. Ipagdasal mo na, bigyan ka ng lakas.
Ako po si Christina Belisario, ipinanganak po sa Abra at ngayon nakatira po sa North Caloocan. At dito po ako ngayon sa bahay ng kaibigan ko po at nakikigamit po ako ng wifi mo. Dati po akong OFW, umuwi po ako noong 2018. At nung habang naghihintay po ako ng paggamot, tinutulungan ko po yung kaibigan ko na gumagawa para hindi ako po ma-stress. Gumagawa po siya ng yema candy at tinutulungan ko po siya ng magbalot. Pero dahil po sa pandemic, ay bawal po ang magkakapitbahay. Kaya ngayon, ang ginagawa ko po ay nagtatanim ng mga halaman po at nakaka-relax din po sa akin. Pero nung nasa Hong Kong po ako, nung nararamdaman ko po sa sarili ko na may bukol po na maliit pa po noon, pero siguro dahil sa pagod, nai-stress po ako, ay unting-unting lumalaki. Pero dahil po sa ayaw po pong malalaman ng amo ko po, tuloy-tuloy po pa rin tinatago. Pero nahihirapan po ako sa sitwasyon ko noon. Pero dahil sa ayaw ko po mawalan ng trabaho, tinago ko po sa mga amo ko ang sakit kong ito. Pero dumating yung time po na minsan nag-day off po ako, ay dumiretso po ako sa hospital dahil nakakaiba po ang aking nararamdaman. Pero habang tinecheck up po ako ng mga nurse, doon po nila nalaman na malala na po pala ang aking breast cancer. Stage 4 na po. Kaya po napilitan po akong umuwi ng Pilipinas ng 2018 po. Pagdating ko po dito sa Pilipinas, ang masakit lang po ay imbes na uuwi po ako na masaya, hindi po dahil hinatid po ako, sinalubong po ako ng ambulansya po mula airport, hinatid sa East Avenue po. Ang pinagkakabalahan ko po sa buhay ko ngayon ay minsan po nagluluto ako ng Shanghai para lang po meron akong gagawin at hindi pa boring ang aking buhay at hindi ko maisip ang aking kalagayan po dahil hindi pa ako nakakapagpagamot dahil po sa kakulangan po ng pinansyal. At minsan nagtatanim po ako ng mga halaman, iba't ibang halaman po para makaka-relax din po sa akin. Ang pinakamahirap po na moment po ng aking pinagdadaanan ay wala po akong karamay at karamay at kagapay po sa buhay. Madalas po ako mag-isa, pumunta sa ospital, magpapakemo, dahil ang mga anak ko po ay lagi silang ayaw ko man po sabihin ng parang walang suporta. Yun lang po ang aking parang masakit po. Pero dahil sobrang hirap ang emotional, bukod pa sa sakit na physical na sakit araw-araw habang ako ay nakikipaglaban po. Gusto ko lang po sana may suporta sa kanila sa akin. Pero dahil siguro sa matagal kong nawala sa kanila. Kaya po, parang bali winawala po ang nararamdaman ko po. Na kahit nakikitang nahihirapan po ako, ay parang baliwala lang po sa kanila. Hiling ko lang po sana sa gobyerno, sana mag-provide sila po ng maintenance at yung libreng check-up po. At sana po wala pong discrimination dahil po sa aming mga stage 4 ay hindi pwedeng lumapit sa DOH po. Hindi ko po alam kung anong dahilan. At saka sa PhilHealth po, yung C-package ay hindi po kami kasambli. Dahil sa stage 4 na daw po kami. Yun lang po, sana lahat-lahat po ay matulungan, stage 4 man o hindi, para po pare-pareho kaming mabigyan ng gamot po. Kaya ang hiling sa gobyerno, sana po matulungan po kaming mas bigyan po ng pansin ng mga stage 4 po dahil pagka hindi po pinapansin na sinasabing hindi kasali, iniisip ko po na dahil siguro stage 4, wala nang pag-asa sa buhay. Parang ganun po ang aking nararamdaman po. Kasi lumapit po ako sa DOH, sinabi ko pong stage 4, hindi na raw po kasali. Yun po ang sana naman sa mga gobyerno, pare-parehas din, wala pong discrimination sana po. File po ako noon ng medical po. Nung pagdating ko pa lang po dahil inaasahan ko po na sila mismo ang tutulong dahil po ako'y matagal ng isang OFW po. Pero hindi po pinansin po ang aking application dahil sabi nila po ay maghintay. Hanggang po sa ngayon wala po akong nahintay. Sana naman po matagal po naman ako nagbabayad ng uwan nung nasa Hong Kong po. Sana naman mapansin po yung application ko po. Salamat ko po sa na naka-member po ako ng Kasoso Foundation po dahil sila po ang lagi kong tinatakbuhan, lagi kong hinihilingan po ng tulong at hindi po ako nila binibigo. At lahat po ng laboratory ko po na hiniling ko po sa kanila ay pinagbibigyan po ako. At maraming po salamat sa Kasoso Foundation at yung mga namumuno po dahil lagi po sila nandyan at tumutulong sa mga pasyente katulad ko po. Maraming salamat po.
Recording in progress.
Ako si Jose Meares Calase, nakatira sa Prater Bansod, Lumbayan. Pinanganak ako noong June 12, 1941. At ngayon, nandito ako sa Laguna sa aking anak na Sauli, nakatira. At sa aking kalagayan ngayon, na may sakit ako na kanser, ay nagpasalamat ako sa Panginoon kasi siya pa rin ang merong plano sa aking buhay sa edad kong 80. Nung ako'y wala pang sakit talaga ang ating buhay ay nandun sa tubigan, pagka madaling araw pala ako, pagbalik sa bahay, tubigan naman. Kaya yan ang ating gawain nung wala pa akong karamdaman. Kaya naniniwala ko na ang buhay ko noon ay napakalakas. Mga anak na nagatulong sa akin, anak sa una, hindi. Kaya ako'y nagpasalamat sa Panginoon kasi hindi ako pinayaan aking mga anak at manugang. Kaya nagpapasalamat pa rin ako sa Panginoon na sa edad ko ngayon na 80 na edad.
Totally ang una namin pangangailangan talaga sa pinansyal na pambili niya ng mga gamot. Kasi yung mga gamot niya totally talagang kumbaga hindi na namin makayanan. Problema yung pambili niya ng gamot sa ngayon. Kaya kami, kumbaga, talagang kailangan namin humingi ng tulong sa ating pamahalaan. Kumbaga may ano naman, pwede maitulong. So, yun yung ano namin talagang humingi kami ng tulong. Kasi ma'am, totally, yung nagastos namin sa PGX, mulat-mulat, gumastos na rin kami ng mahigit 200,000. Nalibre na yung iba sa PGX, naka-discount kami sa kanyang senior, sa PhilHealth, malaking tulong din yung sa PhilHealth sa amin. Kaya yung sa ginastos namin, how much more na marami na, wala naman trabaho si tatay sa ngayon. Ako wala rin. Halos ako na lang yung nag-aalaga sa kanya sa ngayon, kaya wala din kami trabaho. So, totally umaasa na lang talaga kami sa aming mga anak sa lahat ng gastusin namin. At yung mga gastos namin na ngayon na yung gamot niya, nagkakahalaga ng 2,500 per tablets per din yun. Kaya yung tablet na yun na yun ang inauna hindi namin kailangan kung bibili namin talaga. So ang gamot niya pang lifetime na yun. Ang gamutan niya na tablet maintenance na kumbaga.
Ngayon po ay nakapakinay kami ng may batas sa ating pamala na makatulong sa mga kailangan, lalo na sa cancer na may sakit ako. Sana bigyan nila ng kataon na matulungan na ako dahil wala akong pang-bilis talaga ng wala. Sa kahirapan, yan lang pong sa ating gobyerno para umababa pa ang ating buhay. Yan lang po ang ating hiling na matulungan naman ako. Kaya ko kaya sana umababa pa ang ating buhay. Dahil sa tulong ng ating pamahalaan. Yung kinahintay ko. Sa atin wala akong magawa. Kung pira. Kaya ang tulong na lang ng ating pamahalaan ang kinahintay ko. Kaya't narito ako ngayon, may karamdaman naman na sabi na ay cancer. Kaya naniniwala ko sa Panginoon na siyang magbigay ng kaukulang kagalingan dito sa aking karamdaman.
So kung kami nakakaranas ng ganitong mga pagsubok, mga problema, kahirapan, how much more yung iba naming mga kaibigan, mga kapatid na halos sa pang-araw-araw, wala sila, hindi na nila mapunan yung kanilang pang-araw-araw na pamumuhay. How much more na kami na dumaranas ng pagsubok din na ganitong sitwasyon ng aming buhay. Pero nagtitiwala kami sa Panginoon na siya yung tumutulong sa amin at lalong higit sana sa ating gobyerno na tumutulong sa lahat ng mga tao na ganun yung sitwasyon ng buhay. So sana doon nakatuon yung kanilang tulong. Makita nila yung mga tao na ganun yung sitwasyon ng pamumuhay.
changed my name thinking that it would change my mind. I thought that all my problems, they would stay behind. I was a stick of dynamite and it just was a matter of time. Oh dang, oh my, now I can't hide. Said I knew myself, but I guess I lied. It's okay, it's okay, it's okay, it's okay. If you're lost, we're all a little lost, and it's alright. It's okay, it's okay, it's okay, it's okay. If you're lost, we're all a little lost, and it's alright, it's alright. It's alright, it's alright, it's alright. I wrote 100 pages, but I burned them all. Yeah, I burned them all. I blow through yellow lights and don't look back at all. I don't look back at all. Yeah, you can call me reckless, I'm a cannonball. I'm a cannonball. Don't know why I take a tightrope and cry when I fall. Oh dang, oh my, now I can't hide. Said I knew what I wanted, but I guess I lied. It's okay, it's okay, it's okay, it's okay. If you're lost, we're all a little lost, and it's alright. It's okay, it's okay, it's okay, it's okay. If you're lost, we're all a little lost, and it's alright, it's alright. It's alright, it's alright, it's alright. It's alright. Oh, it's alright. It's alright. It's alright. Oh, it's alright. Oh, it's alright. It's alright. It's alright to be lost sometimes. It's okay, it's okay, it's okay, it's okay. If you're lost, we're all a little lost, and it's alright. It's okay, it's okay, it's okay, it's okay. If you're lost, we're all a little lost, and it's alright, it's alright. It's alright, it's alright, it's alright. Yeah. It's okay, it's okay, it's okay, it's okay. If you're
So tunay po na nakaka-inspire ang mga binahaging kwento ng ating mga cancer patients na sa gitna po ng kinakaharap na sakit ay naipakita pa rin na nariyan ng pag-asa, lalo na kung hawak kamay na magtutulungan para makamit ang mas maayos na kalidad ng serbisyo para sa cancer control. So to wrap up our program, may we invite our speakers and panelists to change their Zoom background according to their advocacies. The organizing committee has sent in the chat box the link to access the Zoom background. So just kindly download the image that you prefer. So I think we have childhood cancer, the gold one, lavender for all cancers, pink for breast cancer, gray or white for lung cancer, and blue for prostate cancer. So just add the image and change your Zoom background accordingly. Over to you, Doc Len.
Okay, thank you again. While we're all trying to change our backgrounds, thank you everyone for joining us in the day one of the first historic DOH-WHO Cancer Control Stakeholders Summit. To formally close our program, let us hear Dr. Nestor Santiago, Assistant Secretary of the Department of Health, for a closing message. And after this, we will look at everybody's background.
Good day to our speakers who shared their time and expertise today, to our panelists who led informative and insightful dialogues on cancer control, to our partners who made this event possible, and most importantly, to our stakeholders who joined us this morning to learn more and discuss ways forward to strengthen our country's cancer control program. The first DOH Cancer Control Stakeholder Summit has brought us all together, health experts, policymakers, and advocates, to play a role in the future of cancer control in our communities and our country. The day one of this summit informed us of where our current efforts are in cancer control. Today, we heard the World Cancer Report, the progress updates in the implementation of the National Integrated Cancer Control Act, and our plans to strengthen our policies and programs. May these milestones and plans guide us to where we envision ourselves to achieve our goal as we continue to implement the National Integrated Cancer Control Act. Through our continuing collaboration, we can achieve better survival and better quality of life for people with cancer. See you again tomorrow for the second day of the summit, where we will focus on the World Health Organization Global Initiative for Childhood Cancer and our National Childhood Cancer Prevention and Control Program. Looking forward to your active participation just like today. Thank you, and may you enjoy the rest of the day.
Thank you. Thank you very much, Dr. Santiago, for closing our program. So today was a truly wonderful and historic milestone as we continue to work towards the implementation of the National Integrated Cancer Control Act. And as Dr. Santiago just said, may all that we have learned today guide us to achieve better survival through our hands. I know we have a lot of other things to say and we understand, but every good thing must come to an end. And so thank you to all of you, our panelists, speakers, guests, and audience, and may God bless you for the rest of the day. Bye. Join us again tomorrow. We will start at 9 o'clock.
Yes, and this concludes our first day of virtual summit. Again, to our speakers and panelists, attendees and guests, and of course to our streamers from Facebook and YouTube. Thank you for staying with us. So we invite you again to join us tomorrow for the day 2 of the first DOH-WHO Cancer Control Stakeholder Summit, which will focus on childhood cancer. So for those who haven't registered, you may use the link in the chat box. Again, this is Dali Manalastas.
And Dr. Lorenzo. Bye. Thank you.
See you tomorrow. Thank you.
Bye.